powered by the Milmet. As you all know, the theme for this year is Tamil Nadu Smiling and Tnoa Shining, and we have been doing that exactly for the past 6 months. We have been having an array of programs, starting from the Walk the Talk series, the Tnoa ARC PG Catalyst series, and of course the Tnoa Connect series, connecting all the major institutions with every specialty of ophthalmology being covered. We have received wide appreciation and response for all these webinars for the past 6 months. Apart from that, Tnoa has been very active in the Publish and Prosper, wherein we acknowledge and reward people who got peer-reviewed publications, the ophthalmic photography competition, the ophthalmic video league, the Tnoa national quiz, which have happened twice, and of course we're going to have next month the Gurukulam Tnoa on all Sundays of April, with of course more than 20 faculty and more than almost 50 topics to be covered. All this wouldn't have been possible without the team which I have. The team Tnoa, consisting of the president, president-elect, the vice president, the secretary, and treasurer, and all the other office bearers, the chairman ARC, of course, and the editor, and the members of the management committee. Needless to say, all have been really a fantastic team and solidly behind all these programs. And I'll be failing in my duty if we don't acknowledge the support of Milmet, and particularly Raju and Hitendra and entire Milmet team, which has been powering this Tnoa ARC PG Masterclass. The main objective of the Masterclass is to focus on a particular topic which is very relevant to the postgraduates and residents across the country. And that is why we are doing this Masterclass, so that people who are logging in, the residents and the postgraduates, will learn from this, because this is all exam oriented. And today we have none other than the authority in Retina, Dr. Manoj Khatri, and he is a visiting consultant to Rajan Eye Care. He's got his own hospital, eye docs, and he's a fantastic vitreoretinal surgeon. And we're going to have a master class on retina, on medical retina today. The two masters, Dr. Manoj Khatri and V.R. Saravanan from Aravind Eye Hospital, Coimbatore. And of course, we have got fantastic panelists as well, which Dr. Rajshekhar, our chairman ARC, will be introducing. Friends, for your information, this is the 6th master class which you've been having. The first one in October 2021 on optics and refraction by Dr. Vijay Raghavan, and second one on cornea by Dr. Srinivas K. Rao. The third one in December by Haripriya on phaco and SICS. The fourth one on glaucoma by Dr. Satyan in January. And last month we had a very good one on oculoplasty by Dr. Sendil Nathan and Dr. Usha Kim. And this month on medical retina, which is by Dr. Manoj Khatri and Dr. V.R. Saravanan. The main objective, as I told you, is to disseminate the knowledge, not only for the postgraduate, but also for the practicing ophthalmologists. And that is why we push the masterclass from 7 to 7:30 p.m. and going on till 9:30 p.m. so that even the practicing ophthalmologists can also join this webinar. With these few words, I hand over the proceedings to Dr. Madhavan, our dynamic secretary of Tnoa. He's been doing a tremendous job. I always call him the unsung hero, very competent in whatever he does. And Dr. Madhavan to say a few words.
Thank you. Thank you, sir. Thank you, dear President. Dear President, Dr. Mohan Rajan, our dynamic and innovative ARC chairman and moderator of the day, Professor Dr. Rajshekhar, and the wonderful Dr. Sriram Gopal, our joint secretary of Tnoa, and of course the renowned course masters, Dr. Manoj Khatri, Dr. Saravanan, and panelists, Dr. Mahesh Shanmugam and Dr. Rajiv Raman. Members of Tnoa and all the members who are logged in to Facebook and YouTube for today's Tnoa ARC PG Catalyst Masterclass on Medical Retina. Good evening and welcome to today's virtual knowledge transfer, as indeed knowledge is power. Tnoa is in the forefront of public awareness programs on glaucoma during this week. The launch of Project GAP, Glaucoma Awareness and Prevention, and book release by our President, Dr. Mohan Rajan, Glaucoma Awareness Rally by Tambaram Ophthalmic Society, and the glaucoma programs by our President-elect, Dr. Ramakrishnan Sir at Trinalveli Aravind, and of course, the Go Green for Glaucoma, innovative glaucoma title-based cricket initiative at Trichy by Mahatma A Hospital are some of the initiatives of Tnoa this week. Every week is innovative and Tnoa is shining under the masterful leadership of our President, Dr. Mohan Rajan. I'm looking forward to today's webinar on medical retina. Thanks for the opportunity and looking forward to a wonderful webinar today.
Thank you, Dr. Madhavan. I would like to acknowledge the efforts taken by two people here. One, Dr. Sriram Gopal, as the Joint Secretary of TNOA. His contributions to TNOA are simply immense, and he's also been coordinating this masterclass along with Manoj Khatri. Thank you, Sriram, for all the help you've been doing for the inputs you've been giving for the TNOA as a Joint Secretary as well. And of course, welcome Dr. Rajiv Raman here into the panel, one of the top guys from Shankar Netralia Authority of Retina. Good evening, Rajiv. Thanks a lot. And of course, our chairman ARC, Dr. Rajshekhar. This guy is really so dynamic. And if I tell something today, it'll be done yesterday by Dr. Rajshekhar. And that is the competence level of Dr. Rajshekhar, his efficiency and his ability to mix with everybody. The rapport he creates with everybody, his dynamism is something incredible. Dr. Rajshekhar will be moderating all these masterclass series, and I will hand over the proceedings to Dr. Rajshekhar now.
Thank you, President Sir. And this is a great event. Really, TNOA ARC Masterclass is a brand now. And for the panelists and the master instructors who have joined us today, we are into the 7th or 8th program of this series. And we have a huge following. And the main target audience is our postgraduates, young fellows, and young ophthalmologists. And there are a mixed crowd in that way. Some are listening for the concepts, and some know the concepts and listening to you for the small nuances which you are going to give from your experience. So I will wish and I will request the master instructors of the day, Dr. Manoj Khatri. It's a very novel idea, Khatri. One scan, one pair. So that about OCT and OCT angiography. I also invite Dr. Saravanan, who is a prolific VR surgeon from Coimbatore, with multimodal imaging, a topic on multimodal imaging, looking with dyes and without. And we are very privileged, the TNOA ARC Masterclass is very privileged to have two who's who of vitreoretina today as our panelists, Dr. Mahesh P. Shanmugam from Shankara Eye Hospital and Dr. Rajiv Raman from Shankar Netralaya. They'll be free to interrupt and even give their views and comments on the discussion. And for all your awareness, we have also opened up the chat box for all listeners to type in their queries. We'll be voicing them. I and Sriram will be voicing them. So at those times also, your points and your thoughts are most sought after. So without much ado, we'll start today's masterclass.
Rajshekhar,
Yes,
I just want to make a comment in a lighter vein. I've sent a letter to the Chief Minister of Karnataka. We don't want Kaveri water, but we want Maheshwaram back in Tamil
Yeah.
We all echo that.
True, sir.
We all echo that.
ஆனா எம்பிஎஸ் காவேரியோட பெரிய ஒரு சண்டையை கிரியேட் பண்ணிடுவாரு தமிழ்நாடு கர்நாடகா. Then we have to do
You
lot
keep
of
the water,
liaison and
but send Mahesh to us.
true, sir.
That
Very
is the
true.
authority
Very
of
true.
Mahesh.
Yeah,
Fantastic.
very true, sir.
Great.
A person whose every word, full stop, comma, and punctuation mark is listened with so much of eagerness and respect by almost all who practice the specialty of retina. May I invite Dr. Sriram to give his opening remarks before we start with Manoj? Sriram?
Yes.
Sriram?
Sriram. Sriram?
Panelists, yes, sir. Can you hear me?
Yes,
Yeah,
sir.
yeah.
Thank you. So much has been said both about both our esteemed panelists and our masters. Whenever I hear the word master, I only think of the Kung Fu master style. I keep imagining Manoj doing that. So I'm sure Manoj will have much more to tell us than any other Kung Fu master. And Saravanan as well, who's such a renowned surgeon. And MPS sir, I always, I have a nickname for him, which I haven't told him. I call him the Ethan Hunt of Retina. So I'm sure you know Ethan Hunt of Mission Impossible. So he's like Ethan Hunt of Retina. And my good friend Rajiv Raman, who's so well experienced and so knowledgeable regarding the latest. I think Rajiv Raman knows the result of a study even before it is published. That much things are in his fingertips. So Rajiv is like that. So we have a very good collection of 4 eminent people here. And I'm
They
sure
will
there are
ask
a lot
him
of
only,
people-
Sriram, they will first consult with Rajiv and then only publish the results.
Only then publish. Yeah, that's what I'm saying. So he knows even before the result is published. So that's what. So we have a very esteemed gathering here, and I'm sure there are a lot of people logging in through different modes to listen to such a wonderful topic today. I don't want to keep people waiting anymore for this. So let's kick off with Manoj. Manoj, the stage is yours.
Manoj, all yours, Manoj.
Good evening, everyone. Hope my slides are visible and I'm audible.
Yes.
Thank you so very much, everyone, for the kind introduction and gathering for this wonderful evening today and learning about the most important thing which are there in retinal imaging, especially the medical retina imaging. And the way imaging world is changing, especially for the medical retina, and this day is not far where we are going to get a scanned image from the anterior segment to the posterior segment of the eye, including the optic nerve, the vitreous, and all the structures in detail, right in front of you within fraction of a second. And you will be telling the patient what to be done rather than even before examining the patient. So this kind of technological changes are there. They are necessary very much. And as and when the technology is evolving, we are also learning quite a new bit things with this technology. And some of the rare problems have been sorted out to a very significant extent with the advent of technology. So the topic I've selected for today is one scan, one pearl is like, we should be knowing what to be looked for in that particular scan rather than before ordering the particular scan. So no financial interest in the talk. As we all know, when we were resident, we have been taught to go to the pathology department or histopathological department and look at the layers of the retina like this with a particular pathology at hand. And even before when Mahishanmugam sir and all were trained, but this was the thing what was there in the hand, and then from this to this, that is a significant change. It's a change which have been very good for the imaging world. And as we know, important diagnostic tool OCT is there to treat, diagnose, and follow up of all the retinal diseases. Main advantages is non-invasive and extensively can be used in day-to-day practice, and it's typically an optical biopsy. This is the way OCT has been evolved over a period of time, and now we are in an era where OCT-A has become a reality, that is OCT angiography, and so on. So the evolution is there. As the technological changes are happening, and over a period of time this evolution is quite beneficial, and 2 things which have been a game changer, especially in the management of medical retina in the last decade or so. One was an OCT and the second was an anti-VEGF therapy. Over a period of time, this OCT-A itself is undergoing a lot of revolution, and we are seeing AngioView type of an OCT, like a Angio OCT type of platform. And over a period of time, this Angio OCT has been also incorporated into the Swift Source platform, which has been quite dramatic change over a period of time. So, considering before going to the pathology, just to understand the basic principle of an OCT machine is based on the Michelson's interferometer, which is a low coherence interferometry, non-contact, uses the light in the spectrum of 830 to 850 nanometer, and that images are captured with a time delay. So, because of the time delay concept, this was the principle of a time domain OCT. Over a period of time, the time domain has been replaced by spectral domain OCT, in which there is a spectral interferogram. In fact, when I was a resident with Dr. Raji Raman, this was the time when we were excited about this technology, and we had almost all the commercially available machines in the in the market at that time with us, and we were trying to understand these different pathologies over a period of time. And now we are at that verge of Swift Source OCT, which gives us even finer details. So the basic, the differences in the image acquisition, the scanning speed, the axial resolution, and the transverse resolution, and range of imaging. So the range of imaging improves with Swift Source OCT, no doubt about it, as well as the finer details what we can see over a period of time. So these are the couple of images. This is a time domain OCT, a normal looking time domain OCT. This is a patient with a SD OCT, and this is a patient with Swift Source OCT. So the imaging is becoming better and better as we are advancing over a period of time. These are the commercially available machines. Let's not go into the details which of all these particular machines. But what we have to understand is the higher we go on the platform, the better is the image resolution. But also we need to understand what we are looking for in that particular scan. So the most important thing here is we need to go sometimes to the machine itself and to see the various different scans what you have taken, and then try to analyze and come to an interpretation before advising any treatment to the patient, rather than just looking at a particular scan. So I've just taken this tabulated comparison between Heidelberg, OptoView, and Zeiss Angioplex platform, which are commonly available. Heidelberg gives the best resolution, but again OptoView and Zeiss are equally competent. So whichever platform you are using, you need to interpret the machine, the pathology at hand on that particular platform. There are certain prerequisites, though they are not mandatory. The pupil should be adequately, enough to get you a clear scan. Though you can get a even in 1 or 2 millimeter pupil can get a decent enough scan. Appropriate scanning protocol should be followed based on the particular machine what you are using it. Area of interest should always be kept in mind. We are not only imaging fovea as of now in all the patients, we are looking at even beyond equator. So whichever area of interest is there, you need to tell the photographer to get the scan of that particular region, and patient is instructed accordingly. So these are common types of scans which are there in any OCT machine. So we go with the radial scans, which are particularly typically with 2 scans to start with, radial and horizontal. Then you go to 4 line, then you go to 6 line, and so on. So we can get easily in any platform about 48 line radial scan. Then you have something called as a raster scan, which is very commonly used nowadays. Gives you a quite good resolution and also understanding of the particular disease. Again, in raster, you can have a single line, 7 line, fast scan, and so on, and a dense raster scan. So these are the way we normally look at retinal layers now. And before we start the interpretation of the OCT scan, look at the patient's particular, the date of the scan, the eye which have been scanned, and also try to interpret this like a visual field report. So start from the beginning and go to the end. So either you can go into out or out to in. That's what we call it. So either you can start from vitreous, look for the changes in the vitreous, then the vitromacular interface or vitrofoveolar interface. Look for the foveal dip, whether it is present or not. Then look at the inner retinal layer, outer retinal layer, the retinal retinal pigment epithelial layer, and the RP Brooks membrane. And also we are the recent interest, especially in last 3 to 4 years, have been shifted for the choroidal imaging in a very big way. So we are trying to analyze the choroidal layers in a very significant manner, especially whenever from the advent of from the knowledge of the pachychoroid spectrum is there. We will come to that in a little while. So whenever we get a scan, we can have a two types of interpretation of an OCT scan. Either you can do a quantitative analysis or you can do a qualitative analysis. So what do we mean by quantitative analysis? We can have as a retinal thickness as one of the quantitative analysis. That means the thickness of the particular retina, especially the central subfoveal thickness, what we are interested in. We can have a center point thickness, okay, or we can have a central subfield mean thickness. So these are the three ways where we can do a quantitative measures. This is little varied on different machines what we use scan to scan. So that's the importance of using one single platform, especially when you are doing clinical trials and also on. So the quantitative assessment is very important, which Dr. Rajiv will enlighten us as in due course. And this is the way a typical retinal thickness scan looks like. We can either image the central 1 millimeter, we can image the 3 millimeter zone, or we can go to the 6 millimeter zone. So you can, based on the grid of area of interest, normally we are interested in 1 to 3 millimeter zone, what is happening. So you can quantify the scanning of the particular region. Then when we come to the qualitative assessment, this qualitative assessment, especially in last 2 to 3 years, our interest is more on the qualitative assessment. What is changing in the morphology of the retina? That is what we are more interested in. So in this, a gray zone image looks like this, which we are normally like to see as any retina specialist or even any ophthalmologist will like to see a gray zone images, which gives you much more detail than a colored image. So when you look at this particular image, we need to see whether there is a hyperreflective things, whether there are hyperreflective zones, hyperreflective bands, or hyperreflective zones. So everything has a significance. We will come to all of this in a little while in detail. So just keep looking at the hyperreflectivity or hyporeflectivity in a nicely acquired scan. Abnormal reflectivity can be due to various reasons, but the common causes are like exudates, which are there in the retina, hemorrhages, scar, and so on. And when you have a hyporeflectivity, we already know as the principle of ultrasound B scan that any fluid will cause a hyporeflectivity shadow. So similar thing goes for a OCT scan as well. So what we don't interpret only this macular region alone, we look at the entire scan at hand. If you are having a swift source platform including the optic nerve, so you start with the vitreous, look at the posterior cortical vitreous, what are the changes there, then you come to the vitreomacular interface, go for inner retinal layers, outer retinal layers, then ISOS junction, then the retinal pigment epithelium, and then the choroidal layers. So the choroidal layers imaging is quite possible with most of the OCT platforms available nowadays. However, the interpretation is a challenge and we need to understand lot many things before interpreting this. And last comes the sclera, which can also be seen in good, nicely taken swift source OCT platform. So as I already said, this is the way we are going to look at every scan which I've been going to discuss, and also in our routine clinical practice. But the most important thing before reading any scan, we need to know what is the indication, why we have advised the scan, what is the area, wherever you have advised the scan has been covered, and what are the protocols have been used, what is the signal strength. That means if the OCT image is of a good quality or you want to repeat it, sometimes we do a repeat scan as well. And a thickness assessment and all, we'll just leave it like this as of now. It is not much of an interest in routine clinical practice. But any other prognostic factors, this is what is of prime importance nowadays, and especially when the advent of or understanding of OCT biomarkers, especially the retinal vascular disorders. These are one of the game changers which has happened over a period of time, especially in the last 2-3 years, the way we manage these patients. So let's start with a couple of scans. Start with vitreomacular interface. So whenever we are looking at the vitreomacular interface, first we are looking at there is a VMA, that is whether the vitreous is attached to the foveal or perifoveal region. Is there any traction, if at all it is attached? Is there any proliferation of any abnormal membranes, and whether there is associated any other macular pathology? So typically a vitreomacular interface or a vitreomacular adhesion should look like this if at all the vitreous is attached to the perifoveal area. The posterior vitreous is attached to the 3 millimeter of fovea here with no secondary changes in the retinal layers. So this is what is a normal scan. Vitreomacular traction can be multiplanar as has been seen in this patient. There is a vitreomacular traction here. There is an epiretinal membrane here causing tinting of the fovea, And also when the tenting of the fovea is there, it is also causing the bulge of the neurosensory retina here. So this is a clear-cut indication that the patient will need surgery. But what has changed in the recent past is something known as a whisper classification for prognosticating focal vitromacular traction. So this is of a little significance, which I thought it's a little theoretical, but we should be knowing it. So what is a whisper classification? They know, they want to classify what is the width of vitreous attachment. That means how much of the vitreous is attached. What is the width here? Whether it is a point focal attachment or it is involving little bit of amount of retinal area as well. What are the interface features? What is the shape of change of the fovea? What are the changes seen at the retinal pigment epithelial layer? An elevation of vitreous attachment and inner and outer retinal changes. Does this make any significance? Yes. All of this makes profound amount of significance. So these are the changes what I discussed, whether this is just a point attachment with little bit of foveal tenting which has been there, something they have classified as a grade 0, that means just a focal tenting, or there is a single area of vitromacular adhesion which has been pulled out, including the inner retinal layer, and there is a presence of epiretinal membrane here which is also causing the tenting. Clearly this patient will need surgery at some point of time, and this patient has an epiretinal membrane with central 1 mm ATDR circle or continuous vitromacular traction, what we called as. So these kind of understandings have changed over a period of time, and they have also classified as shape, which is a normal looking shape here. This is a grade 1 abnormal profile with loss of perifoveal curve here, and then this clear eversion of the central layer. So these kind of changes have changed over a period of time. Then you look at whether there is any pigment epithelial disturbance, whether are associated in intrusions or RP atrophy. So we are not looking just at the scan. So this is of prime importance, that you look for everything, including the elevation of the retina, the maximum retinal thickness which has been taken care by the vitromacular traction, and so on. So this is the significance which has been changed over a period of time by this whisper classification. And in our routine clinical practice, the implementation of this has become of prime importance. We are not looking just at the scan, we are also looking at what are the associated changes on that particular vitreoretinal pathology or fovea interface. Now, when you look at just the epiretinal membrane, normally initially days where we just used to see whether there is an epiretinal membrane and the foveal contour which has been altered, that's it. We used to say this patient will need surgery at some point of time, and also look for cystoid macular edema, and that was the thing which we used to classify this patient and treat accordingly. But what has changed in this recent past is something called as a what is happening to this inner retinal layers. So this is of prime importance, and these changes in the inner retinal layer based on the progressive changes in the visual acuity has been classified accordingly. So this change is called as ectopic inner foveal layer, which indicates poor visual prognosis. Even if you take care of this ERM by the best available surgeons like MPSR and all, even if they operate, this patient is not going to get hit much on the visual acuity gain, because this inner foveal ectopic layer or inner retinal layers have become slightly ectopic. So this has been recently classified into stage 4 stages, 1, 2, 3, 4. So this is of prime importance in looking at these kind of scans. There are some other changes which comes on the second level. It's called as a tractional abnormalities of central bouquet in ERM. So basically we are looking at this photoreceptor layer here, magnified view of this photoreceptor layers here, in which the traction, there is a epiretinal membrane, but what is it causing? Whether it is causing any central bouquet changes here. So what you can see here is a stage 1, that is cotton ball sign, what is it called as. The stage 2 is a foveal detachment, and another stage is something like a vitelliform type of a material which has been deposited here. It has certain kind of significance, especially whenever you are considering surgeries for these patients. And they say that like ectopic inner foveal layers are kind of a protective against this kind of a central bouquet abnormalities, but we have to see its clinical significance, and we are going to learn about this in due course of time. So this is about the vitromacular interface. The commonest disorder associated with vitromacular interface is something called as a macular hole. We are all familiar with. But before interpreting any scan with a macular hole, first ask yourself whether the macular hole is degenerative in nature or it is fractional. Tractional means there should be obvious traction which is pulling tangentially across the retinal layers. So if it is a degenerative, the prognosis is not that good, but if it is a traction, the prognosis is better. So this is what is a first significance. And degenerative further has been classified as stop at, and a mustache type of classification has been given for tractional epiretinal membrane, which is causing lamellar macular hole. So everything has a significance. This can be sometimes associated with lamellar hole associated epiretinal proliferation and so on. So this we should be looking at it. So lamellar hole associated proliferation is commonly called as LHEP, has gained little significance recently because we are thinking that this originates from the Muller cells and may not independently affect the visual acuity prognosis. But we need to differentiate this from a premacular membrane, whether the membrane is pulling it. So this is the significance of knowing this particular area. We can enlarge or zoom the scan and look at for this particular pathology. Before even the advent of OCT, a great Donald gas has classified macular holes into different stages, and still the macular hole stages remain the same even after OCT undergoing so many advanced changes. But what we have to understand is whether we are dealing with what stage of macular hole, 1, 2, 3, 4, because whenever the macular hole is there into consideration, we need to have a clear-cut prognosis, because most often or not these patients need surgery. So over a period of time, macular hole has been reclassified by something called as the International Vitromacular Traction Study Group, and they have also told us lot many stages, right from VMA, that is vitromacular adhesions, to VMT and so on. But what we need to understand is what is the minimum macular hole diameter. So this is a commonly encountered thing. Whenever we look at the scan of a macular hole, we go with a caliper, manually measure this. There are automated softwares also available, but mostly it is done manually. And based on this minimum hole diameter, we further classify it as macular hole indices, whether you are going to operate this patient, whether these indices are going to help you to prognosticate and also to plan your surgery in some cases, as compared to like hole form factor, which is most commonly used, and macular hole index. The other things are still evolving and we are learning about all these things. There's something called as a diameter hole index and traction hole index, but these two are commonly encountered or practiced as something called as a hole form factor and macular hole index. So basically we are measuring the minimum hole diameter in this, and then you divide with the maximum basal diameter and come to a conclusion. So something over a period of time, macular hole index also has been looked into it. A hole form factor of more than 0.9 and macular hole index of more than 0.5 have good prognosis surgically. Though this is not an image of a type 2 closure, don't look at this. I didn't have a good type 2 closure image, so I just inserted this image here. But type 1 and type 2 closure, that means it is a U-shaped closure or a V-shaped closure. That's what we are worried about here. So you can see here this patient has a degeneration of ISOS layers, so the visual acuity in spite of a type 1 closure will not be that great. What has been prognosticated beforehand itself by looking at this scan here, though we achieved a good type 1 closure surgically, that is a U-shaped closure, but ultimately the visual acuity have not, which patient has not gained much of visual acuity. So this is all the importance of knowing the hole form factor and so on, and planning the surgery and prognosticating the surgery in the to the patient clearly before operating. Traumatic macular hole, as we all know, that has a very good prognosis of something called as a spontaneous closure. So on similar lines, it has been reclassified into 5 stages. These are just for theoretical interest. I don't have to go in details of this, but we need to see whether there is also some kind of a cyst which are present. That means the macular edema is there, or assisted macular edema is there, or there is thinning of the neurosensory retina. These are the main 2 prognosticating factors. But most often or not, we wait for almost 4 to 6 months before touching these eyes, and by about 4 weeks or 6 weeks, they undergo spontaneous closure. Coming to the other common pathology in day-to-day practice is something like a diabetic macular edema. So here there are 5 stages which we should commonly know, and that is more than enough most often or not to manage these patients with diabetic macular edema. The first and foremost is something called as a diffuse retinal thickening. That means the entire retina or one part of the retina is quite diffusely thickened, both in the inner segment as well as in the outer segment. Then you have development of a cystoid spaces, We had a lot of interest in the past in knowing these cystoid spaces, whether there is more on a horizontal separation or on the vertical separation. You can still look into that, especially when the newer concepts of something called as a drill and all are coming into place. We will see what are they in just a moment. Or there are some kind of a a subretinal fluid, not because of the pull but because of the swelling of the retinal edema per se. This also indicates a pure systemic control, especially poor renal function for that particular patient. So you have more amount of subretinal fluid here, or causing a neurosensory detachment. If the area is more involved, the response to the treatment is not that great initially, and you need to keep this patient on subsequent treatment. So these are all prognosticating signs and also trying to tell us. Next comes is the traction macular edema, and also we are learning something called the vitroschisis. Initially the vitroschisis were termed we used to see only intraoperatively, but nowadays with OCT the understanding of vitreoretinal interface and this kind of traction edema, which straight away are the indications for surgery, are quite common nowadays. But understanding how much of the vitroschisis is there, where are you going to plan your incision, how are you going to like incision for the epiretinal membrane, I'm saying, and how are you going to handle this membranes over a period of time has changed quite dramatically, and whether this traction is causing more amount of stress on the inner retinal layers or on the outer retinal layers, and causing ischemic changes here also as of quite significant. So identification of these membranes have become quite significant, and then definitely comes a vitromacular traction. This is one of the favorite slides of my Shanmugam sir, where any kind of traction seen in the eyes with early proliferative diabetic retinopathy, even if it has a nasal prolif, there is not much of a temporal prolif here. We think of early surgeries for these patients rather than treating them pharmacologically over a period of time. We have seen early surgical intervention in these patients gives much better results than managing them initially pharmacologically and making this traction worse, or can happen over a period of time even by a good pan-retinal photocoagulation. And last but not the least is something called as a tractional retinal detachment. Our understanding of this particular entity based on OCT has become very significant in recent past. And also with this tractional retinal detachment is alone, or it is also a combination of a combined retinal detachment. That means there is a component of a regmatogenous retinal detachment as well. That means the retina has developed some kind of a break somewhere, and most often or not they are at the point attachments of the polyp or at the base of the polyp. We need to look at carefully. There are a lot of biomarkers and a lot of work has been done by especially Dr. Rajiv Raman on this already. So again we start from outer to inner here rather than inner to outer. So what are we looking at first? First we are looking at ISOS disruption, ELM disruption, hyperreflective foci. How is the cystoid spaces in the outer plexiform layer? How is the outer nuclear layer? Disorganization of retinal inner layers, and if there is any associated vitromacular traction. So these are the OCT biomarkers which helps to prognosticate us whether the patient is going to benefit with your pharmacological treatment to a very significant extent or a very less extent. So this patient has a ERM here, which is a fine looking ERM. There is a disorganization of retinal inner layers. External limiting membrane is disrupted. ISOS disruption is there. So this patient is not going to benefit with treatment much, though you have to still treat this patient, as compared to this patient who is going to benefit much in spite of having hyperreflective dot foci here. There is no disorganization of the inner retinal layers on the one side, especially here, and also here. ISOS is preserved, ELM is intact, and cysts are mainly in the inner nuclear layer and outer, not in the outer plexiform layer. So these are all good prognosticating factors. There are certain other biomarkers that assist in the outer retinal layers, ELM disruption of the fovea, and so on. So it has to be looked carefully. Preferably go to the machine, look at the particular scans at different zones, and then only take a call. So SDOCT as a predictor of non-responders and DME has taken a very significant space in today's world. Basically, we want to know whether the patient is going to benefit with anti-VEGF treatment or not going to benefit with the anti-VEGF treatment. So the presence of cystoid spaces in inner retinal layers at baseline, they are the worst response to anti-VEGF treatment, as compared to diffuse macular edema without cystoid spaces, good response to anti-VEGF treatment. So this is a recent concept, but it also depends on patient to patient, and we need to take a lot of factors into consideration before we decide on a particular modality of treatment or the prognosis for that particular patient. The other thing which diabetic macular edema sometimes can resemble is something called as a pseudophakic cystoid macular edema, though it's very less nowadays, but we need to keep this in back of our mind. It's commonly called as Irwin Gas syndrome. The differentiation, whether initial days we always used to do fluorescein angiography for this patient, but you can just get away with an OCT if you're basically you're looking at it is the cysts are purely in the nuclear layers, presence of SRF, and also absence of any microaneurysms, hard exudates, hyperreflective foci for inner retinal thickening. So if these are the indicators that the patient has a pseudophakic cystoid macular edema, and the treatment slightly changes as compared to a diabetic macular edema. OCT in retinal vein occlusions more or less is on the similar platforms. I have not taken too much into detail. However, we just need to know whether we are dealing with ischemic or non-ischemic type of CRVO, and then only come to a conclusion and the interpretation of particular OCT scans. OCT-A especially is quite useful. We will be going through some of the scans, especially for ischemic central retinal vein occlusions. This patient had hemiretinal vein occlusion, or even called as hemicentral retinal vein occlusion. But there are a lot of good prognosticating factors here, because the diseases are come in the category of retinal vascular diseases. So we don't have to go into the detail, but have a lot of good prognosticating factors, so that this patient can benefit with a minimal amount of intervention. Again, this one of the patient had a fresh branch retinal vein occlusion, as what you can see here, with the shadowing kind of a macular edema here, but the inner layers are quite intact, so has a better prognosis on the treatment protocol. Very rare occasions where we do come across OCT in central retinal artery occlusion or a branch retinal artery occlusion, very rare entity. But what we have to see here is the retinal edema is mostly quite dense, and it involves the inner retinal layers. We sometimes have to classify this patient based on OCT as something. What you see here, if the pathology is mostly arterial, that means coming from the arterial circulation, it will involve mostly the inner retinal circulation. But if the pathology is coming from behind, as in some kind of a tumors, or especially the choroidal spread of the some kind of a breast carcinoma or lung secondaries, then the pathology sometimes can come from the involved outer retinal layers also. This patient was treated immediately in our OPD, and you can see as a very good favorable amount of OCT in a couple of days time. Though visual acuity didn't achieve 100%, but we had almost 50% of visual acuity gain. So a quick OCT rather than doing fundus fluorescein angiography and all helps us a lot in the understanding of this particular disease. A lot of interest have been generated in recent past on knowing some entity called as PAMM, that is paracentral acute middle maculopathy. It denotes focal ischemia of deep retinal circulation. It can be either idiopathic or secondary to some pathologies, and it's a hyperreflectivity. The acute stages shows hyperreflective bands here. It can be focal, though this patient has a diffuse hyperreflective band here, but most often not, they are seen in patches, so it's called as a focal. And multicolor or multimodal imaging is one of the clinching diagnosis for this particular imaging modality. I'm sure Dr. Saravanan will be covering that. And also we need to sometimes be aware of rare situations like acute macular neuroretinopathy and so on. OCT and AMD, especially dry and also wet AMD, has been a game changer in last a decade or so. We start with common pathologies, that is drusen, as a commonly seen as amyloid deposits seen in the below the RP. But over a period of time, the drusens have been classified using different platforms, fundus fluorescein angiography, or OCT, or fundus autofluorescence, which is of a very significant role, especially in the patients who have macular degeneration and so on, or color fundus photography. So typically the hard drusens, they are slightly more hyperreflective. That means the hyperreflectivity will be more as compared to the soft drusens, which are less hyperreflective. And we need to always correlate these findings clinically. So just don't look at the OCT scan, interpret it clinically as well, and then only take your call. So these are the cute autofluorescence image showing so nicely the distribution of cuticular drusens or basal lamellar drusens, what are they called as. And OCT looks like this, there are multiple bumpy elevation, RP elevations, what we called as, and also over a period of time doesn't cause much of a visual acuity change, but we need a close follow-up of these patients. Then there is something called as a reticular drusen or a pseudodrusens, where you have this kind of outpouchings here. It comes and disrupts the inner photoreceptor layer, slightly more significant in nature, as this can cause visual disturbance over a period of time. Then comes secondary, the pigment epithelial detachment. So we can have various type of pigment epithelial detachment. The most common is something called as a fibrovascular pigment epithelial detachment. Then we have a serous pigment epithelial detachment, in which the choroidal differentiation is quite easy. We can still see the choroidal layers in detail, and also make out some changes which are happening here. This is presence of subretinal fluid here in this particular patient. And also drusenite pigment epithelial detachment. That means the drusen itself has coalesced together and caused a drusenite pigment epithelial detachment. In this, the area involved should be more than 350 microns in diameter when it's classified as a drusenite pigment epithelial detachment. Why you want to know this is it can progress to neovascular AMD and geographic atrophy in the due course. Then we have something called as a hemorrhagic pigment epithelial detachment, in which the differentiation of choroidal architecture or the study of choroidal architecture is not possible. As you can see here, it's nicely seen the Haller's layers and the Sattler's layers, but here the differentiation is not made out. So most often on this patient has a hemorrhagic PEDs. There is something called as a RP rip, that is retinal pigment epithelial, which just strips off. Initially, we used to diagnose this only with based on fundus fluorescein angiography, but nowadays OCT is more than enough. We can see here there is an abrupt cessation of retinal pigment epithelium. This is the retinal pigment epithelium layer here. You cannot see here it at all, and it has just ripped apart because of the tense amount of fluid which is present in form of hemorrhages or serous in nature, or even sometimes after treatment, and then just can rip apart. There is something called as a double layer sign or a fat irregular PED, which has to be carefully looked in any patient, especially in our Asian subset population. Almost 30% or 40% of patients do have some component of idiopathic polypoidal choroidal vasculopathy. So all of us will not have fortunate enough to have a high speed or fundus fluorescein angiography or ICGA, that is intracerebral green angiography at hand, or sometimes there will be a contraindication. So OCT itself can give you a lot many indicators whether the patient has a component of IPCV or it has just a neovascular age-related macular degeneration related CNVM. So all these signs have to be looked into, especially the double layer side. So how does a type 1 choroidal neovascular membrane looks like? Though this is a chronic choroidal neovascular membrane here, but what we can see here, there is not much of activity or neovascular membrane complex seen here above the level of retinal pigment epithelium. Though there are some changes in the outer retinal layer denoting the chronicity of the disease. So this patient most often not will classify into type 1 CNVM. So with current advanced modalities or treatment modalities, we are not really worried about type 1 and type 2 CNVM, but we should be knowing for our own knowledge whether the patient has type 1 or type 2 CNVM. As compared to a type 2 CNVM, where we can see here there is a disruption of retinal pigment epithelial layers and the choroidal neovascular membrane complex extends above that. This most commonly this patient will have a type 2 type of a CNVM. And the third variety is something called as a RAP, that is retinal angiomatous proliferans. RAP, especially the OCT, plays a very significant role. Even a good angiography is needed, but most often or not we rely more on OCT changes. So here there are typically 4 or 5 changes. What we see here is presence of a fibrovascular PED, that is pigment epithelial detachment, presence or absence of subretinal fluid, inner retinal cyst, outer retinal cyst, both are there, and also some amount of drusen. So these kind of changes indicate that this patient has a RAP lesion and will need treatment for some time. There are almost close to 20 changes which have been described in the literature, which have been published in last 3 to 4 years. In fact, there is a conference itself on this imaging conference itself on knowing the different kind of changes which have been seen, especially in AMD cases. I've just taken 2. One is called a STEM, which is of little significance and easy to pick up. This is nothing but a focal deposit of material which is little hyperreflective in nature above the retinal pigment epithelial layer. This patient got one anti-VEGF injection, and what you can see here, the STEM is contracted and indicates a good prognosis for that particular patient. And something called as ORT, that is outer retinal tubulations. This indicates chronicity of the disease, and also in a way tells us that this patient will not benefit much with any further treatment. or we can use treatment as a PRN basis. The other thing which I've already highlighted, that OCT is one of the game changers in knowing this particular disease, something called the pachychloride spectrum. I think 2014 was a time when we first came to know about this disease. Per se has 5 changes. That is something. First is pachychloride pigment epitheliopathy, pachychloride neovasculopathy. That is PCV is the third common form of this. That is polypoidal choroidal vasculopathy. Then definitely central serous chorioretinopathy is supposed to be the form, spectrum of pachychloride, not a retinal problem, and also focal choroidal excavation. So we need to have a good quantitative assessment of the choroidal layers, especially the halars and the saccular layers, and we also need to see whether there is a attenuation of the choriocapillaries. So polypoidal choroidal vasculopathy typically will have a thumb-like polyp, what we call as, and sharp PED. The PED margins will be sharp. Okay, so this is a sharp margin of the PED, and there will be a tomographic notch in the pigment epithelial detachment. We see a hyporeflective shadow here, and also double layer sign. So these are the things what you look at. You don't look at the though these are more than one pulse, but we also need to look at all these changes which are happening. How is the dilation of the choriocapillaries? How much is the extent of area which is involved, both including the outer retina and the inner retina? How acute is the bend? Sometimes this bend can be very acute, indicate that the RP can rip off. So all these things. Central serous chorioretinopathy is one of the game changers, especially with the swift source OCT platform. What we have understood here is we are looking at the thickened choroidal layers, and also over a period of time giving some kind of a treatment, this choroidal thinning can occur, and this is what is called as a degenerative photoreceptor foci or layers, which can be seen here in indicating the chronicity of the problem. And this is a area where typically you can see the deposit of the CSR material here, fibrin material here. Invariably, it will indicate that the leak will be somewhere here if you do angiography for this particular patient. So these are a couple of things which we have learned in CSCR patient. We don't initially we used to do a lot of angiographies every 3 months, 4 months to know what is happening, especially with patients with multifocal CSR. Nowadays, angiography is more or less common, is done at least at the baseline, and maybe on the very less frequent follow-ups. So only OCT we can gauge and prognosticate and treat these patients fair amount of time or not. These are some of the changes which can be seen on the chronicity of the disease, showing the entire disruption of the outer retinal layers here, indicating poor prognosis. Very rarely we need to see with an eye whether the patient also has a component of choroidal neovascular membrane. Though this patient only had a what you call a focal central serous retinopathy, but what you can see here, the OCT is telling us some kind of a hyperreflective material sitting here, can be indicating that the patient also has associated choroidal neovascular membrane, and in these cases the treatment can be slightly different. So you need to look at these subtle changes, pick them up early, and then treat it accordingly. Choroidal cavitary disorders, very rare. I've just taken this image from one of our patients, where you can see here there is a focal choroidal cavitary thing, or we call it as an excavation. Very rarely this can be associated with choroidal neovascular membrane and so on. So you need to differentiate and prognosticate and tell this patient whether they will benefit from treatment or not. There are certain non-age-related macular degeneration causes of choroidal neovascular membrane. One of the commonest one is traumatic choroidal neovascular membrane. This patient has a choroidal rupture, and also at this stage didn't develop a choroidal neovascular membrane, but in due course develop a choroidal neovascular membrane. So we need to look at the clinical picture as well. This was a subsequent follow-up where the patient developed a CMVM and needed treatment for the same. Angioid streak, one of the very rare phenomena, can happen, but we can see it clinically. Unless and until we look for it clinically, we will not be able to pick it up. There is an active choroidal neovascular membrane here with a subretinal fibrosis, and this kind of streaks which are present here. The newer interest has been generated in last 5 to 7 years on an entity called as MACTIL. This is nothing but a juxtafoveal or a parafoveal telangiectasia which has been renamed. Basically, we are looking at whether this patient has a aneurysmal type of a problem or just a degenerative type of a problem, because the prognosis and the is slightly different in both the entities, and the choroidal neovascular membrane has to be looked into it at every follow-up visit of these patients and been treated accordingly. This is one of our rare patients who develop choroidal coloboma related choroidal neovascular membrane. The diagnosis was quite challenging, but we made a diagnosis of this particular problem based on OCT and treated those patients. And this was only seeing eye of this particular patient, and he benefited quite significantly. So this kind of a subtle pathologies can be very easily picked up. You have to tell the photograph that you have to scan this particular area of interest. That's the reason I put this scan. Though if you just take a look clinically, you will never say that this patient had a choroidal neovascular membrane, but the OCT was showing some kind of elevation changes here, and over a period of time after treatment responded quite well. So these kind of subtle changes have to be looked into it. OCT in high myopia has its own sets of challenges, but with newer modalities of investigation, our understanding of these diseases is changing quite dramatically. We'll come to that one by one now. There are something called as a paravascular inner retinal cyst, which has to be looked into it, whether there are any microfolds, lamellar holes, traction, macular hole, or CNVM. This was one of the hyperreflective scan of a patient who had a myopic choroidal neovascular membrane, though it was quite big in size. Normally, this kind of CNVMs, they are very subtle and small in nature, but causes a significant amount of drop in vision or the discomfort to the patient. This patient was treated with anti-VEGF monotherapy and got quite benefited with this kind of a treatment. This has particularly changed our interest, especially when you want to have a surgical indication, and we have two surgical masters, both NPS sir and Dr. Savanan here, who will fully agree with me that myopic traction maculopathies, the surgical indications are purely based on OCT changes, and we do something called a serial follow-up of these patients based on OCT scans and also visual acuity changes. So we classify here myopic traction maculopathy with inner retinal schisis. That means the schisis is there on the inner retinal layers or outer retinal layer. Though this patient has more of outer retinal layer changes, but what you can see here, there is a schisis on the inner retinal layer changes as well. Then myopic traction maculopathy with inner and outer retinal layer schisis. That is a schisis here and also here, and also whether it is causing some kind of a elevation of the neurosensory retina, and also whether the patient has some kind of a macular hole, whether it can be full thickness along with epiretinal membrane sometimes, and causing a posterior pole retinal detachment altogether. These are the most challenging cases to manage, but if the surgery has been done quite carefully, the results are very gratifying for these patients. Last but not the least, in myopic spectrum, very rare entity is something called the dome-shaped maculopathy. Initially, we were not knowing the importance of this but whenever this is a vertical scan of a horizontal scan of this patient. So whenever you suspect this kind of problem, it is advisable to get a vertical scan, and this is a vertical scan showing the DSM, that is a dome-shaped maculopathy. It doesn't require any treatment, but it was just from the academic interest. OCTs in dystrophies, I'm sure I'm not going to touch more on this because Dr. Savanan is going to cover more of multimodal imaging, because we prefer multimodal imaging here. But commonly seen changes are epiretinal membrane, if you see retinitis pigmentosa, you see epiretinal membranes, cystoid macular edema. You need to know the extent. You need to differentiate this from a pseudophakic or other types of macular edema, but most often than not, this patient also has undergone cataract surgery, and also atrophic changes surrounding the fovea or the perifoveal region, and so on. We need to differentiate it from other disorders like a cone dystrophy, where you will not have much of a disruption of inner retinal layers, and so on. And also definitely need to classify or differentiate these patients from a juvenile X-linked retinoschisis. So clinical examination plays a vital role, but OCT is one of the clinching diagnoses for this particular entity. Best disease, definitely OCT has a lot of prognosticating factors for this patient, whether you want to treat them or just observe them. And you typically look for that this vitelliform dystrophy deposit, and sometimes we also get nowadays something called the adult onset vitelliform dystrophy, which is a variant of Best disease, and you need to look into these patients quite carefully. Another one of the rare presentation in our clinic was a choroidal cavitary disorder. This was a torpedo maculopathy, which was initially confused as a vitelliform lesion. So we need to be little more vigilant and seeing these patients. Definitely OCT has been indicated in any uveitic pathology. Basically, we are not only looking at the vitreomacular interface changes or the retinal changes here, we are also looking very carefully at vitreous cells. These are posterior vitreous cells in a patient with pseudophakic cystoid macular or inflammatory cystoid macular edema, and there is a definite traction here, but These kind of subtle changes has to be picked up quite well on the OCT, and it tells you a fair amount of diagnosis and also the treatment prognosis and how are you going to manage these patients. Inflammatory CMM definitely has to be very carefully looked for into even on the routine clinical examination. But what we have also understood nowadays is this is something called as a pitchfork sign. That means you have a fork which has been inverted and put it there. And though the pathogenesis of this particular condition is not known, like why does this sign occurs, we don't know. But it's been diagnosed as one of the very specific entities for a inflammatory choroidal neovascular membrane disorder. Another common entity which has been very recently described is a bacillary layer detachment. Basically, it's a fluid accumulation in inner segment of myode and commonly seen in conditions like APM-PP or VK syndrome. And resolution correlates best with visual acuity improvements. Choroidal granuloma, definitely OCT is one of the game changers. We need to not only look at the hyperreflectivity, but we also look at the hyporeflective foci, the separation of fluid from the granuloma material itself, and so on. So the other findings are out of scope of this lecture, but we can have look into lot many things rather than just looking at the OCT scan of any patient with choroidal granuloma or similar condition. People have also described a lot of interest in looking at PAM not as an isolation, but also looking at especially at the optic nerve head-related disorder. This has been recently published as a PAM can be one of the presenting symptom or as a presenting finding for patients typically who have a anterior-ischemic optic neuropathy of the ischemic variety. So these patients have to be looked quite carefully. We are not only looking at what's happening in the retinal architecture, but we are also looking at what's happening at the optic nerve head level as well. So there are a lot of recent advances. I am sure Dr. Rajiv will give his inputs because he is involved in lot many technological advances segment, including wide field OCT, color Doppler OCT, polarization sensitive OCT, adaptive optics OCT, and OCT microangiography, which is going to be the future. There is also a lot of interest have been developed, especially by Anand Vinekar group, as something used as a handheld OCT, especially for the pediatric eyes. Basically, whenever you look at the pediatric eyes or infant eyes or preterm infant eyes, at the more you need to know the retinal anatomy as well, rather than just interpreting the OCT as compared to the adult OCT. So we need little bit of reading on this. The adult, the preterm OCT or the retina looks slightly different as the what we call the representation or the separation of the retinal or the differentiation of retinal layers is not that significant or that has been taken place. So we need to look into all this. There will be a shallower foveal depression, thinner retinal layers, thinner photoreceptor layers. So rather than telling this patient has a poor prognosis, we should know that the photoreceptors are still not developed, and persistence of inner nuclear and plexiform layers at the fovea causing foveal immaturity is always there as compared to a adult OCT. So first look at the scan, the age of the patient, how the scan has been done, and then only interpret. This is going to be the future, the way we are going to operate intraoperative OCT. It's been there in few centers, though I don't have any personal experience with this. It's going to be the future, which is also going to tell us how we are going to operate these patients and give us a good cleavage plane for dissection. Home OCT definitely has become a possibility. We have done for a single patient here who is non-mobile, has a severe amount of diabetic macular edema, and another patient who has a neovascular age-related macular degeneration. Very simple to assemble. It just takes about 15-20 minutes for the machine to assemble. Can be sent at patient's home. And even if the patient is bedridden, they just have to recline a little bit forward and can be recent amount of image can be captured and it can be emailed to you immediately. So this is going to be the future. And just a brief touch upon angio-OCT. We are not going to go in details of this because of lack of time. This is what a normal octa scan looks like. The octa scan, that is OCT angiogram scan, can be of the superficial capillary plexus, middle capillary plexus, or deep capillary plexus. So this interpretation of this particular scan has to be done accordingly. Basic principle is there is a flow wide pattern. We all know this. Again, it's a non-invasive imaging technology and takes less than a second to image the patient per se. I'm just going to skip a couple of slides here because of lack of time, but we can start from anterior segment to angle visualization, the patients who have proliferative diabetic retinopathy per se, and so on. As you can see here, the foveal contour is slightly disturbed and the FSZ is slightly disturbed. So this patient has a ischemic type of ischemic changes there. Another patient depicting quite good amount of ischemia here. We don't need an FFA for this particular patients. Over a period of time, our understanding with OCT, especially for diabetic retinopathy related changes, have been quite significant, and a lot of insights can be measured as one more foveal avascular disruption. This is what a prime importance. And you can have an on-fast image as well. You can take multiple scans of different regions, club them together, and image these patients over a period of time. So ischemia over a period of time quite well documented, and also you can see the progression of ischemia or also resolution of this. Whether the resolution doesn't occur, but how's the treatment response for that particular patient? As you can see here, the FSZ is completely distorted and disturbed here over a period of time. How the patients respond to the treatment, if that we can judge it. Definitely in CMM is one of the game changers. Knowing immature vessels versus mature vessels, what is the significance will come to in a while. As what you can see here, this patient had a choroidal neovascular membrane in a lazy pattern, and what happens about 8 days after individual therapy. So this kind of a real-time angiography, this background is an angiography image of the same patient, and what you can see an opta image of this particular patient showing a classic lacy pattern of leakage. So we don't need a fluorescent angiogram for this patient. Only an OCTA can be helpful in prognosticating and treating these patients over a period of time. So these are a couple of significant changes of what you can see here. And the patient develop a regression over a period of time, but also has a recurrent CMEM, and we can image this mature versus immature vessels over a period of time. And what is happening to the treatment response can also will be quite well understood for this particular patient. Another patient, what you can see here, there is a background real-time angiographic image versus overlaid by a OCT angiography of the same particular patient. Whatever details you wanted to see, in fact, the OCTA gives you much more better details about the vascular network, what is happening here. So we don't really need FFA or an ICG for this patient. OCTA per se can give us good amount of detail, but we ourselves should be knowing what are you looking at and what information you want from the system, and how are you going to treat these patients over a period of time. Some very rare indication, this patient was seen by me in clinic for the suspected chloroquine retinopathy, which has been referred, but OCTA gives us fair amount of changes what's happening in the foveal and the perifoveal region, and we can prognosticate these patients better in a better way. So OCTA is here to stay, and mostly on the source platform. The future, what we are looking at is something called a single platform machine, where me and Sarvanand sir don't have to give a separate talk. We can have a talk on the same platform, right from fundus photography, good quality image with autofluorescence, with OCT, with OCTA, with FFA and ICG if required, possible in a single machine and a single platform. The day is not very far. So just to wrap up, first we need to understand what information we are looking at from that particular system, and then only advise the investigation accordingly. Don't do an OCT scan and then see the patient and interpret the scan accordingly. OCTA is a revolutionary technology, and it's a very invaluable tool in managing and treating vitreoretinal and choroidal diseases. Newer advances are there for better imaging of the vitreous, retina, and choroid, all three together, not only single thing. An accurate interpretation and use of technology to the maximum is key to gain the maximum outcome for our valuable patients. Thank you so very much, TNA, for this wonderful opportunity and learning from you as well. Thank you so very much. Looking forward to Sarvanand sir's talk now. Thank you so much, Ajay.
But before that, we'll finish discussion on yours. Manoj, we'll finish discussion on yours. I'm sure all panelists will have a lot of points. It was a wonderful class, and I'm sure most of the people who listen to it tomorrow, the very next day, when they see a OCT, they'll see it with more interest, more information, and will be able to pick up new things. We also have a few questions. I'll just read those questions so that the discussion, and we also invite all the panelists and Sriram also to join with it. The first question which I see is the central foveal thickness not at all important, sir? That is one question. Manoj?
It is quite important, and it's more important on the prognosticating this patient, and also on the whenever you are doing some kind of a clinical trial associated with it. I'm sure Dr. Rajiv Raman will have a different view on that and will enlighten us on the central subfocal thickness, sir.
Yeah, what you're telling is correct. Actually, for macular edema, you tend to use the central subfield thickness. It's not a good idea to do a manual measurement because you want that patient to come on a next follow-up and see how the treatment response is. So you want to use the segmentation which is done by the machine itself. Definitely central subfield thickness is an important tool, even to diagnose whether it is center involving diabetic macular edema or a non-center involving. You want to use that, and then on follow-up, how your treatment is responding. Nowadays, people are also looking at volume, central subfield volume as one of the parameter, more better parameter than the thickness. But yes, thickness is important. It's not only for trials, even in the clinical practice, you take a note on these.
And a corollary question to that, they've asked, like, from the old spectral domain OCT, when the patient has the old OCT scans, and we are analyzing the old scans and now trying to do it with the step source machine, the thickness, the numbers, the thickness does vary.
Yes.
How much can we give it as an allocation, or can we take the other eye as a reference? That is a question. That is a question. Can we compare thickness of a SDOCT and a SSOCT?
No, you cannot actually directly compare the thickness between the machines. In clinical practice, you do tend to look at that machine value as the thing. However, there are certain formulas, there are some conversion factors. You want to convert from spectralis, but these are mainly between SDOCT machines. So there are a couple of conversion factors which you can take into consideration when you are looking, but usually in clinical practice, we don't use these conversion factors. The moment you have old scan, you more look into a morphological point of view, a qualitative measure. You don't much rely if you have different machine scans.
Yeah. We have one another question also, sir. In AMD, when we have injected, how much time will it take for the OCT changes, the qualitative changes to establish before we think of injecting again? This is a question. How much time can we allow post-injection for OCT changes to establish?
Normally, we follow this patient every monthly, sir. So very difficult to predict. But studies have shown, even the clinical patients have been shown the response as seen as good as on the first day itself.
Yeah.
But as one example I showed you, what with the patient was we seen after 8 days and showed a good regression. But normally we follow this patient every monthly, and that's more than enough. We don't really look into beyond that as of what current understanding is.
Yeah.
Depends on the duration of the disease. If it is a very fresh, like the CNVM, then you can probably see the response on the first day itself. But if it's a treated patient who already the fluid is lesser, then less are the chances that they're going to have a dramatic change in the first day or the first week. So usually it takes about, even the first week, usually they show some changes. But like Dr. Manoj said, 1 month is when you take a decision whether to treat or not. Again, this depends on the agent you use. If you're going to use aflibercept or brolucizumab, probably 6 weeks to 8 weeks is when you would probably want to take a opinion about treating the patient.
Yeah. So that much. Some more explanation on vitreoskisis. Manoj, one question. Some more. Can you explain more on vitreoskisis?
Yeah, so vitreous cases is nothing but a separation of the vitreous layers per se altogether. We used to see this change initially as an intraoperative change, used to call it as a secondary membrane. And the current initial understanding was used to happen only with either with vitreoretinal, like vitreoretinopathy, like a diabetic proliferative diabetic retinopathy changes, or with something called inflammatory changes like Eales disease and all. But now with our understanding has changed, as we are imaging more and more these patients on the vitreoretinal interface disorders. The significance here lies is you need to differentiate. There is a traction, but you need to differentiate whether it is just a vitreouschisis or if the traction is because of epiretinal membrane proliferation. As it is a vitreouschisis traction, you can sometimes even observe this patient. But epiretinal membrane, the sooner or later will tend to go towards surgery and operate this patient at an early stage. That differentiation is important.
Yeah.
So MPS sir, you would like to add something on this vitreouschisis?
With this cases, not all the time you may be able to pick it up on the OCT, because if it is a thickened membrane like the epiretinal membrane, then you can pick it up. But most often what happens in a myopic patient, again, vitreous cases plays a huge role. So Dr. Manoj showed wonderful images of the myopic traction macropathy. Those people have layers and layers of vitreous. So what looks like the posterior vitreous detachment is not the posterior vitreous detachment. There'll be another layer, there'll be another layer. So vitreous just splits into multiple layers and it's patchily attached all across the retina. So it may be only in the macular region and around the peripharamacular region also there'll be islands of vitreous which will attach. So the importance is in the disease we are managing. So with the myopic traction maculopathy, all these vitreous strands have to be removed for the myopic traction maculopathy to go down. And if the patient has a myopic traction maculopathy also is a detachment, very often we tend to miss that cortical layer of vitreous, which results in the recurrence of the detachment. So that is when, and not all the time we'll be able to pick it up. And myopes, it's difficult to image them on the OCT very, very well. So intraoperatively, we need to look at it very carefully, stain them multiple times to look at the islands of vitreous and remove them.
Yeah. Yes, sir.
I have a question for MPS sir.
Yes, Sriram.
Sir, good evening. Would it be right to say that of all the epiretinal membranes we generally look at, most of them are more of thickened posterior hyaloids or internal limiting membranes thicker rather than true epiretinal membranes?
I would agree to a reasonable extent, but not all of them are, because there have been
No, not
instances
majority,
where you remove
majority, I mean.
Majority, yes, but then it depends. So we have had situations where we remove the hyaloid, then we remove the ERM, then we remove the ILM as well. But there are cases where the ERM is not so mature that you identify the ILM and use that as the handle to peel the ERM. So it is possible, but then I think it depends on how mature the membrane is and the pathology under it.
One more question, Sriram. Now it's being sent in. What is that vertical scan, sir? Please explain that vertical scan. Manoj?
It's just a vertical line scan, sir. It's need not be done.
It's a 90 degrees.
Need not be done
YX. Instead
regularly.
of XY, it's YX.
Yeah, so it need to be done only in one rare instance, like dome-shaped maculopathy is one of the very rare presentations. I've seen only 1 or 2 patients. So in those situations, you would like to use that. It picks up the pathology in a better way rather than a horizontal scan.
Yeah.
Routine practice is not required.
Extension of the dome shape is not all the time innocuous. Dome shape can give rise to a collection of fluid like a settled serous chorioretinopathy, and which may not go away, and you will not be able to identify where it is leaking and treat also. And CNVM can also be associated with dome shape. So the importance of dome shape is these patients will present like CSR, but then unless you have a vertical scan and identify that the dome shape, you will not be able to identify that. And as I mentioned, the importance is like you do an FFR, you may not be able to identify a focal point to do treatment. That's the issue.
I think just wanted to add one thing for postgraduates, because our most listeners are postgraduates.
Yeah.
Very nicely presented, Manoj, this presentation. Just one thing, it is not like, no, not all, everything is OCT. I think you must understand when not to do a OCT. So there are certain like media, still the spectral domain OCT is an important modality, and that works only in a clear media. So if you have media opacities, the OCT is not a great choice. The another thing you should realize, the width of the scan or the amount of area the OCT scan usually covers is about 6 to 9 millimeter. You imagine a dilated pupil is about 6 to 8 millimeter. So that's the only area which is centered at fovea. If the pathology is there, it is picked up. You go to swept source, it increases from there to about 12 millimeter. 12 millimeter is something like 50 paisa coin is 19 millimeter. That means less than that. So that is the area you are covering. So it's not like any retinal, though we saw all retinal diseases have some posterior pole manifestation. But take home message should not be that OCT is something which is to be done for every patient at every visit. You even imagine now we have swept source technology where we have SSOCTA montage that also maximum extends to 15 millimeters. You want to extend it a little more, you put a aspheric glass in front, 20D. It increases by hardly 1 millimeter more. You're looking at 16 millimeter. And if you put a contact lens plus 30 diopter contact lens, it becomes about 17 millimeter, still less than the 50 paisa coin. So that is something which as a PG, you should know that that is the limitation of a OCT. You cannot use this OCT for looking at peripheral retinal diseases, though the picture which he showed is a beautiful, the whole eye OCT, but in practice, we never get that type of a picture. That was one thing. And second thing I wanted to tell about the SWIFT. So he was telling about the choroidal imaging. And so there is definitely this important concept, though SWIFT source came, but before that there was EDI, okay, which Dr. Spade had described this technique. So on the OCT, there is something called as a zero delay line. That's a point of maximum sensitivity. So if that is there, you get a good scan, and that's usually on the inner retinal surface. What happens in what Spade said, that if you move the joystick a little more in the front, this zero delay line goes towards the choroid so that you can image the choroid better. I think this is a traditional in as a PG, you must know how you image choroids. So one is EDI, concept of EDI, and second is swept source technology. So how that helped? One, the wavelength changed. So what he was telling about 840 became 1050. So it had deeper penetration. Second, the scan, the acquisition increased. You had 50,000 scans per second. Now there are 1 lakh scans per second. The source, you had CCD cameras in the spectral domain, that changed to a photo detector. So they were more powerful source. So all these help to get a deeper penetration, getting the choroid and a larger scan. I think for exam, choroidal imaging, these things are very important as a postgraduate.
Yeah. Wonderful, sir. Wonderful. Such a thorough discussion on OCT. So now we'll go to Dr. Saravanan and multimodal imaging. Saravanan, all yours.
Thank you, sir. Just share my screen now. Are you able to see my slides?
Yes, boss.
Okay, sir. So this is almost a very thorough class by Manoj. I think this will be sort of a few repetitive points as well as some clinical scenarios on where you can apply all these points which you learned from the previous presentation. So multimodal imaging is nothing but trying to group the findings from various investigations which are available to the VR surgeon, like fluorescein angiogram, indocyanine green angiography, OCT, OCTA, and as well as clinical photography, and all those things combined together, we try to come to a diagnosis. And each has its own role in each situation. Like it's not like one is only needed in each. So you can, the additional investigations can add on to the information which is gained from one of the investigations. It can either strengthen your diagnosis, give some analysis on how to go about treating, or the treatment response following a treatment. So all these can be used to use multimodal imaging can be used to decide on these parameters. So we'll be mainly talking about the color fundus photography, the OCT, the fluorescent angiography, ICG, as well as the most recent OCTA. Also, some cases are from the fundus autofluorescence also. So this is a old lady who came for a checkup, and she had already undergone PDT, and she came to us with recent drop in vision. And what you see here in the color photographs is some fibrin-like material in the posterior pole with some reddish dots, which could be either hemorrhages or polyps. And OCT, as you can see, there is considerable subretinal fluid. And I can see the thumb-shaped PEDs with the shallow PEDs also. And you can also see the fibrin material, which is there sitting right under the fovea. So a lot of superimposed findings between a CSR as well as a polypoidal choroidal vasculopathy. The amount of fluid is too much. The fibrin is there, which is more seen in central serous choroidal retinopathy, whereas the thumb-shaped PEDs are more suggestive, and the age also is obviously suggestive of a polypoidal choroidal vasculopathy. If you look at the FFA here, you can see that there's a large rip in the inferior quadrant, RP rip, and also there is a smokestack leak just above that level of the RP rip. Apart from, you have some diffuse leakage under the fovea, and this is the fluid leaking from the both the RP rip as well as the smokestack leak. And when I went on to do a ICG angiography in this case, you can see that multiple grape-like clusters and also the branching vascular network in the center of them. So obviously you have signs of what do you call polypoidal choroidal vasculopathy. So you have superimposed, and this was a nidus for a series of cases which was published in a journal about the superimposed findings of CSR with the polypoidal choroidal vasculopathy. And in OCT, you can see the smokestack leak compares to a breach in the or break in the RP, a small micro break or micro rip in the RP, which was the corresponding point for the smokestack leak, which you normally see in a central serous choroidal retinopathy. So all these come under the pachychoroid spectrum. So we have a superimposition of CSR and PCV. Again, because they belong to the same spectrum, we had published a case of around series of 8 to 10 cases where we could see spectrum of both CSR as well as PCV. So the next case is a young female. Her vision is 6'6", but she came to us with referred as a case of papilledema when she had gone for a routine glass checkup. She had a headache and she went for a see if she had refractive error, and they found out that the optic disc was edematous, and correlating the headache, they referred to rule out papilledema. So when you did, you can see that obviously you have a left eye has got a slightly larger disc with elevated margins, and it's blurred. But when you do autofluorescence, you can see that it's actually optic disc drusen. So what looked like papilledema is not a papilledema; it's actually optic disc drusen. And OCT shows that bumpy appearance which you see in optic disc drusen. But more confirmatory is the ultrasound here. You can see like a foreign body, like hyper intense echogenic lesion there in the sitting on the optic nerve in both the eyes, indicating that it's a optic nerve head drusen rather than a optic disc edema. I'm sorry, papilledema. In this case, you can look at this just to show how a papilledema will look like on ultrasound. You will not have a hyperreflective shadow, but you will just have a what you call as a fluid level. It's a crescent-shaped crescent shadow or a donut sign or a crescent sign, which you call. So you'll be seeing around the optic nerve, you'll be seeing a layer of hyperreflective fluid, which indicates that's a papilledema. So you can just by doing ultrasound, you can and OCT, autofluorescence, you can just show that this is not optic papilledema, just optic nerve head drusen. This is a case of an old man who complains of reading difficulty, progressive reading difficulty. And the fundus, you were able to see multiple discrete yellowish white lesions. And the right eye was already blind because of a scarred scene. So this is the only seeing eye. On the left eye, you have multiple drusens. But what was mainly we thought, because he has a vision loss, we thought he had a CNVM, but he didn't have any choroidal neovascular membrane. But what you see was multiple elevation of the irregular elevation of the RP, indicating there's a lot of drusenite PED, and there was no obvious signs of a fluid or CNVM. Then you're wondering why this vision loss is there. But you look at the autofluorescence, you can see that all these hyporeflective areas indicate there is significant RP atrophy. And when you have these so-called hyperfluorescent spots around the hypofluorescent areas, indicates that it's a progressive geographic atrophy. When you have these hyperfluorescent spots at the margin of these geographic atrophy areas, it indicates a high risk of progression. And this is mainly a vision loss due to progressive geographic atrophy. Even though the right eye had a wet AMD, the left eye was losing vision because of a dry AMD rather than a wet AMD. So we could identify this by looking at the fundus autofluorescence picture. So also microperimetry also throw some light into the areas of function and loss of function also. So also in glaucoma, normally we take, apart from the ganglion cell layer thickness, we look at the optic nerve fiber layer around the optic nerve. We can just circular scan just to show how arcuate scotoma will be picked up. You can see that's an inferior notch in this particular patient. And we look at the nerve fiber layer OCT concentric to the optic nerve. You can see just highlighting there, you can see the notch there. You can see that corresponding to the so-called notch, you have a loss of NFL. Then you can see the obvious thinning of the NFL in that particular zone. And this will correspond to the arcuate scotoma. And in the multi-color photograph, you can also see that the NFL loss is seen as a layer of wedge-shaped defect in that inferior quadrant. So you can just see the wedge-shaped defect which picks up on the multicolor picture, which is taken on the Heidelberg machine. So obviously, chloroquine also, some part of it was touched by Dr. Manoj Khatri also. So people who are taking hydroxychloroquine for various disorders like rheumatoid arthritis. So even though the late stage, you'll be seeing the typical so-called bullseye maculopathy, we have to pick up these patients even before they end up with such significant damage. We have to pick up them very early. So you'll be doing a routine HFA 30-2 along with the high definition OCT and also mainly the fundus autofluorescence. So you can see in the late stages, you'll be able to pick up the loss of the alterations in the deeper retinal layers. So you can see the loss of the photoreceptor layer, especially in the parafoveal zones. And you can see the typical so-called satellite sign, which is seen in these OCTs in the little bit more advanced cases. But in the more early cases, what you'll be seeing is this hyper autofluorescence in the FAF pictures or the fundus autofluorescence pictures. This is one of the earliest signs. So we can see this along with the early OCT changes. You'll have to advise your physician to stop the medication. So the increase in the perifoveal autofluorescence on a fundus autofluorescence pictures is one of the earliest signs of hydroxychloroquine. And before you end up with such a significant loss, both in the OCT fundus picture as well as in the field, obviously. So we also do the MFERG to pick up the early loss. So MFERG autofluorescence will be the earliest investigations to show up damage in these cases. This is one more case of a diabetic patient who's been on treatment. You can see that there is some significant retinopathy changes. Even though there is no obvious new vessels, there's considerable retinal edema as well as multiple hemorrhages. And he had a significant retinal thickening in the on the OCT. You look at where all these leakages coming from. You can see the FFA, which adds to the information which you are obtaining from the OCT. You can see extensive non-perfusion areas, and as he had developed a nephropathy in recent onset nephropathy. So that's why all these changes have been very progressive. And all these ischemic zones throw up a lot of VEGF, and all this edema which you see in the macula is mainly VEGF related. And apart from doing PRP to shut down all these ischemic zones and adding intraretinal anti-VEGF therapy is going to be very beneficial in this patient. So what you saw on OCT, you look at the FFA and correlate the cause and then try to titrate or tailor your treatment to that particular pathology, which is the cause for maculopathy here. So this is a case of treated PDR with the CSME. So one of our older cases where we did focal laser, and he came back to us with after 1.5 years with sudden loss of vision. He had improved in vision to 6/12 following a focal laser. You can see that all the exudates have disappeared, but he came to us with sudden history of vision loss, and this is a finding which was shown already in Manoj Khatri's presentation. So this was because of the para. You can see the NV just sitting next to the fovea here, and that had caused a contraction of the vitreous, posterior vitreous, leading to a vitreomacular traction. So without the OCT, this would have been impossible to identify, and doing a surgery for this patient will be helpful to bring back the lost vision. So one more case where OCT was helpful. This is a case where the patient had lost left vision due to a ischemic optic neuropathy, and he had a history of recent MI also. So he came to us with for this left eye mainly treatment. He was in Saudi, so he could not get treatment there, and he rushed down after he was recovered from the MI. But we had his suspicion of a PDR, even though left eye could not be helped. We wanted to prevent vision loss in the right eye because he'll be flying back, and it'll take a long time to come back for a follow-up again. So instead of doing a fluorescein, because he has recovered from a cardiac event, we did a fundus OCT angiography, and you can see the presence of mu vessel, and we confirmed the presence of NVD on the disc, and we went in for a pan-retinal photocoagulation in this particular patient. So this is a young diabetic who had, even though he had close to 6/6 normal vision, he He was complaining of recent onset dulling of vision. He had developed some renal nephropathy also. So even though clinically not much of edema, you can see very few hard exudates. Foveal reflex is very almost normal. So we did a fluorescent OCTA instead of a fluorescent angiography. So this is a 3 mm cut of optical coherence tomography angiography, and you can see the loss of the capillaries in the perifoveal capillary network, and also the deep capillary plexus. Also, you can see multiple capillary non-perfusion areas, indicating that this is a loss because of early onset macular ischemia, which will be difficult to identify in FFA because OCT is much more accurate in diagnosing early onset macular ischemia. So OCT was helpful in identifying the reason for his vision dullness in this particular young patient. So to identify a macular ischemia, you have to go for the small cut. If you're taking a large cut and try to magnify that, the clarity is not as good. So if you want to identify macular ischemia, go for the smaller cuts. So it gives you a much better identification of all the subtle changes which are seen in early macular ischemia. So this is a patient who came to us with vision loss in one eye because of vitreous hemorrhage, and left eye we wanted to know whether we had to laser. So obviously there's a NVD sitting there. Even if there was a subtle NVD, doing a fluorescein, you can see the vitreoretinal cut showing the presence of NVD on the neovascular on the disc. And this sort of collage of the various cuts of the OCTA, showing the extensive capillary non-perfusion and also the optic disc neovascular as well as the peripheral NVE also. So OCTA in select cases can be able to identify the extent of capillary non-perfusion as well as the presence of neovascular. So this is again one more case of diabetic retinopathy. Right eye had vitreous hemorrhage, left eye left eye had vitreous hemorrhage, right eye you're not sure whether he had a NVD or no visible NVD was there, but there was a suspicious lesion in this particular zone. Whether it was NVE or IRME, we were not sure. So you can see that there's an abnormal network vascular pattern there in that area in OCTA. And when you did looked at the B scan, you can see there is no flow pattern above the level of the retina. So now we know that's just an intraretinal microvascular abnormality compared to a NVE which was seen in the previous case. So now when there are no obvious neovascularies elsewhere, you can just observe this eye. So that is one of the advantages of doing a OCTA. So it gives you immediate diagnosis of whether the patient has got a neovascular or not. And if you're not sure, because it doesn't show the leakage part, you have to look at the B scan to identify the level of flow pattern, whether it's inside the retina or it's above the retina. So you can know whether it's an NVE or it's just an intraretinal microvascular abnormality. Just showing the flow pattern which is located within the retina rather than above the retina. So also one more area where the OCT is very helpful, and this part is shown by Manoj also. So normally the distance between the optic disc and fovea is approximately more than 3,500 to 4,000 microns in length. But in this particular case where there's a nasal traction, you can see the disc is pale and the fovea is closely dragged towards the disc. So what looks like a disc pallor is actually not a disc pallor. Without OCT, we'll never be able to identify the reason for the disc pallor. And the reason is when you look at the OCT, you can see that the disc is covered by 2 layers of retina. The yellow area is where the disc is supposed to be sitting, and just above that, you have 2 layers of the retina because of the nasal traction. Retina has been dragged across the disc, giving it a pseudo pallor. So what you see is pallor is not actual optic atrophy, just a pseudo pallor, and doing surgery to relieve this traction will be helpful in these patients. So without OCT, we'll be just diagnosing as a secondary optic atrophy because of ischemic neuropathy in these patients. Also, for surgeons, identifying the second membrane is very critical. So even before the onset of OCT, we've been realizing that there was some additional membranes, what we called as vitreous schisis, which was my MPSR was already talking about. So this is very critical. But when OCT has shown, you can see this just showing the lifting up of the second membrane during surgical steps. Again, there's one more membrane which is running across the macula. So you can see the near transparent membrane which is running across the superior arcade to the inferior arcade. It's a large transparent membrane. So we didn't know what these membranes were, but once the OCT came, we are able to identify this so-called second membrane, which is just lying underneath the PVD. So the top layer is the PVD, and the thin membrane which is lying along the retinal surface is what we call the second membrane. So unless you identify this membrane and peel it, surgery is going to be incomplete and also difficult also. You can see this top layer is the PVD, and the bottom layer is what we call as the second membrane. Again, in a magnified image, is the top layer is the PVD, and there's a thin membrane running across the retina that we call as a second membrane, which is very critical for VR surgeons. This is a vertical scan which came up in the questions, running from top to bottom, from the superior arcade to the inferior arcade, showing the presence of second membrane all through the macula. So unless you identify and remove this, it will lead to a secondary ERM in the postoperative period. So this is one more case of female who came to us with vision loss in her left eye. And so what you see here is she actually cardiac, as you can know, she was already a cardiac patient with some mitral stenosis who was not on proper medical therapy. She was on and off and with poor compliance. She came to us with a field loss. She was saying some sort of scotoma she was seeing. Clinically, there was a subtle edema in the superior part, looking like a reperfused BRAO or some sort of a picture. Very subtle edema that was seen. And it was not clearly visible on fundus examination. So only OCT showed up what we call as already Manoj described as PAM or paracentral acute middle maculopathy. You can see the whitening of the middle layers of the retina on either side of the fovea. So this is what is called as PAM. It's indicative of minimal ischemia. It can be seen in various retinal disorders and also migraine also, and also caffeine toxicity also. So fluorescein will not pick up this diagnosis. It is very critical to do a OCTA or optical electron tomography angiography, and you can see the superficial layers are intact, whereas the deep layers show ischemia. The dark areas indicating that a selective ischemia of a reperfused, probably a branch retinal artery occlusion. So fluorescein would have missed this. OCTA only was able to pick up the cause for the PAM in this particular patient. So this is a case of a wet AMD patient, just to show the various components. Normally, this is what we see in a fluorescein and ICG. The fluorescein picks up the classic component, the component above the level of the RPE, and the ICG picks up the deeper component, the component which is located below the RPE. You can see this patient is a combined type 1 and type 2 disease. You can see the FFA picking up the superficial component and the ICG picking up the deeper component. So now with the OCTA, we can try to correlate because this shows both the components. This is the OCTA picture showing the classic component above the RP, and this is the deeper cut showing the large occult component which is there. So it's trying to correspond the FFA and the OCTA. Look at the classic component here in this cut and the deeper occult component in the OCTA. So both can be picked up, whereas you'll have to do ICG as well as FFA to identify this in routine cases. So OCTA is helpful in this way. So this is a lady teacher who came to us with the mild dulling of vision in the right eye. So we were able to pick up a very subtle change there, a small nodular pattern looking like an early polyp. I was not very sure. So we did, that's the area which was seen on clinically as a small red dot. And you can see the pigment alterations in those areas again. And when you did a OCT, we were able to pick up a small polyp there with a shallow PED surrounding it, and also a little bit of fluid just next to the optic nerve, just temporal to the optic nerve. So we did a OCTA. And this cut shows the polyp, which is in the superficial layers. You can just see that the edge of the polyp there. And the deeper layer, you are able to pick up the BVN or the branching vascular network. So again, we did a fluorescence. This is just to show a running video of the various cuts from the top to bottom. The polyp is seen first, and the bottom layers you are picking up the BVN. We did a fluorescence as well as ICG to confirm. The left is the fluorescence, right is the ICG. You can see the so that is the polyp there and a subtle branching vascular network in that area. So you can just trying to see the superficial cut of the OCTA showing the polyp, deeper cut showing the BVN in this zone. And you can try to correspond that with your ICG. So normally OCTA picks up the branching vascular network much more than the ICGA, whereas ICG picks up the polyps much more than the OCT. So polyp is picked well in the ICG, whereas the BVN is picked well in the OCTA. So you can try to correspond and identify the various components of this disease in this case. There's one more case of a lady who came to us with this vision loss, and you can see that there is multiple small hemorrhages around the fovea, with the alteration in the foveal reflect is more of a grayish surrounding the FAZ. And if you look at the OCT, you can see that this is a abnormal CNVM which is sitting there. If you look at the vascular pattern, you can see there's a parafocal telangiectasia. Again, this was discussed by Dr. Manoj Khatri. So the OCT can pick up both the components easily. So you can see the alterations in the retinal capillary network and also the abnormal vascular growth, that is the CNVM. So both can be picked up in various, this is the avascular retina cut and this is the superficial capillary plexus. Both can be picked up. And in the other eye also similar finding with a lesser, smaller CNVM. This is the avascular retina cut showing the CNVM, and the superficial cut showing the abnormal vasculature because of the mactal or parafocal telangiectasia. Whereas fluorescein sometimes gives rise to a diffuse leakage in the late stage. Without the presence of, in the absence of hemorrhage, it's very difficult to diagnose CNM in looking at the FFA. But OCT gives you a very accurate diagnosis of these cases, and especially in subtle cases where the hemorrhage is absent, you can find the CNM very easily. So this is one more case of old middle-aged man who came to us with a vision loss, but we were able to see some signs of subretinal hemorrhage and signs of some CNVM there. So this is showing the FFA and the ICG. And here you can see the small communicating vessel and underlying occult component. So we have diagnosed a RAP lesion. You can see the central communicating vessel in the middle layers of the OCT. And when you do OCTA, you can see the deeper, the avascular cut, you can see the CNVM complex. And superficial cut, you can see the dipping vessel in that area. So when you try to superimpose, so this is a running OCTA showing that there's a communication between the normal retinal vasculature and the underlying CNVM. So they will be diagnosed as a RAP lesion or retinal angiomatous polycurrents in this particular patient, just superimposing the OCTA on the FFA pattern. So that's the area where the vessel is sort of communicating in that area. So this is, we are able to diagnose a RAP pattern looking at both the OCTA and the FFA and ICG. So this again, relatively, actually a general physician who came to us with a relatively middle-aged general physician who came to us with the history of central serous retinopathy in the left eye. He had undergone 2 sittings of focal laser, and because SRF did not resolve, he has advised injection of Lucentis. Right eye showed the presence of pachychloride, but foveal anatomy was normal, and in the left eye, there was a very subtle fluid clinically and a slight alteration in the pigment epithelium in that area. So you can see the OCT showed the presence of very minimal fluid in the subfoveal zone, along with a very shallow PED, and also obviously pachychloride, as you can see in this enhanced depth imaging cut. So a large pachy vessel underneath the fovea with a shallow PED and some amount of fluid. This was the FF which was taken outside. You can see a diffuse leak in the left eye. Not very helpful. We were not able to show why this was happening and why she was not responding to his focal laser. So look at the OCTA. So superficial capillary plexus is normal, deep capillary plexus is normal, but when you look at the deep avascular retina, we're able to pick up a subtle abnormal growth of vessel. It's what we call as a PCN or a pachychloride neovasculopathy. And OCTA is very critical to identify the subtle case of PCN, which is easily missed on routine angiography. And this is the superimposing the color photograph on the OCTA. You can see that where the RP alteration was seen, that's the area where there's a shallow PED. Underneath the shallow PED, we have the so-called PCN sitting just next to that. And probably doing a PDT or anti-VEGF may be helpful rather than just a focal laser in this particular patient. So this is the case of a young male who came to us with a vision loss in his right eye. And what you see is actually a tuberculoma. And not only that, you have a abnormal communicating vessel into the so-called inflammatory mass. And not only the mass, you're seeing some sort of subretinal hemorrhage surrounding the mass. When you look at the OCT, you have a big elevation of the RP and choroid in that area. And do a OCTA, you can see a big network. It's not only inflammatory mass, now it's all vascularized. And there is a series by from PGH Chandigarh where they showed that Avastin is helpful in treating patients with the tuberculoma because it's a lot of vascular components in this present in these cases. And here we did both oral treatment with ATT as well as intravitreal anti-VEGF. Both was treated, and after probably 3-4 months, you can see the flattening of the lesion with more of scarring. And this you can OCT showing again the flattening of the lesion. And you look at the OCTA, even though the vasculature is not fully dead, we can see the decrease in the amount of vessels which are seen in the initial picture. So just highlight some of the indications where you can apply various modalities and try to bring them into a signal diagnosis and sort of coherence between all the findings which you see in various modalities, and try to sort of superimpose one on each other to come to a diagnosis, and also look at the treatment response. So I'll just stop here and open up for discussion. And thanks for the opportunity. I'm thankful for TNY as well as Mohan Rajan sir for giving me this opportunity. Just shop sharing, and we can probably discuss some of the application which we do in routine clinical. Thank you, sir.
Very good. Saravanan, fantastic.
Thanks, sir.
Fantastic. As usual. Brilliant. Rajshekar, you can open the panel.
I think you are muted. We can't hear you.
Yeah.
Actually, it doesn't show him as muted, but he can't hear his audio. No, still no audio, Rajshekar.
Okay, before Rajshekar comes, I would like to compliment Saravanan for the wonderful array of cases and the various situations and the application of the OCT, OCTA in the fundus fluorescent angiography, and the clinical interpretation, which is very, very important for not only the ophthalmologists practicing, but also for the residents. I think it's important to know the clinical scenario and probably interpret them. Saravanan, hats off to you. Lovely pictures, lovely case scenarios, and lovely,
Thank you, sir. Thank you, sir.
yeah, lovely discussion as well on each of these various. Now, I open it to the panel, Dr. Mahesh and Dr. Rajiv. Any comments on this? Mahesh?
The beautiful images showing the gamut of cases, wonderfully illustrating the use of each of those diagnostic modalities in each of the clinical scenarios. Very nice, Saravanan. And of course, it's a very exhaustive lecture by Dr. Manoj, all encompassing about the OCT also. Let me just add a few things for the sake of the postgraduates. The autofluorescence is something which tells us about the health of the retinal pigment epithelium. It just shows us if there is accumulation of lipofuscin. So retinal pigment epithelium accumulates lipofuscin and before it dies. So when there is accumulation of lipofuscin, it is not able to metabolize it, then you get hyperautofluorescence. So you get a autofluorescence is more there. And then once the retinal pigment epithelium dies, then you get hypoautofluorescence. So that is the basis of it. So that's why an aging retinal pigment epithelium will show hyperautofluorescence and a dead retinal pigment epithelium will show hypoautofluorescence. And as far as the OCT interpretation is concerned, you just have to look at four things. It's just a vitreoretinal interface, foveal contour, if it is elevated or if it is being pulled or if it's being pushed, and the retinal structure and the RP choricapillary structure. If these four things are looked at, most of the diseases and most of the things which you want to cover in as far as the OCT is concerned will be covered. And like Dr. Saravanan mentioned, how do you differentiate the IRMA versus an NBE on the OCTA? You can differentiate it on the OCT as well. On the OCT, if the neovascular network is above the internal limiting membrane, that's an NVE. If it is under the internal limiting membrane, it's an IRMA. That's how it is. And Dr. Manoj talked about how do you make Dr. Rajiv also commented about how do you make a regular OCT into wide angle OCT. Other thing which we have described is to just hold a 78 diopter lens in front of the OCT machine. You can get a wide angle OCT almost up to the equator. You can run an OCT, and even Octa you can do it. One of the things you need a steady hand and a cooperative patient to some extent.
Very good.
And just a difference between just one last comment: Octa versus invasive angiography. Octa allows us, the main advantage of Octa is it allows us to see where the pathology is, layer by layer in the retina. Whereas the invasive angiography, because it's a 2D image, it just shows that it's leaking from somewhere, and we have to make it out. Okay, if it is below the leakage is just below the retinal vessel, then we think it's subretinal. So that's how it is. But Octa literally tells us where it is leaking from, whether it's leaking from within the retina, whether it's leaking from under the RP, whether it's leaking from under the retina. So that's the main advantage of Octa. Disadvantage of Octa is it doesn't show leakage. So in case if you want to treat a patient of CSC with focal laser photocoagulation with an Octa, we don't know where it is leaking from. Though there are some indirect clues, like there is an area of choricapillary non-perfusion, but it is not good enough to help us treat. We can go ahead now.
Yes, sir. Yes, sir. Yes, sir.
Yes, yes.
Thank you for that. In fact, as I was sitting and listening to Saravanan, I was thinking all cataract surgeons today for eye and IOLs have made OCT a default investigation. IOL master and OCT are two default investigation. So Saravanan speaks about all this multimodal imaging, then all these will become default. That was what I was thinking. And MR is smiling. And few questions, Saravanan. One is that
Yes, sir.
about the macular ischemia. You said about thinner cuts. Can you
Small-
explain
smaller
that a
cuts.
bit?
The current OCT machines, OCTA machines have a 3, 6, 8, and 12. So normally you want to see everything in a wider way. So you take 12 millimeters and try to magnify and look at the phase margin. It doesn't give a clear image. So if you want to look for macular ischemia, it's best to go for the 3 millimeter cut, which will give in much more clarity. So enlarging a 12 millimeter cut will not give you the adequate resolution to identify various structures. So 3 millimeter cuts gives you a better. So depending on what you want to look at, try to choose that sort of cut. Either you want 3, 6, 8, or 12.
Yeah, yeah. And can we
The word
distinguish
cut
that
is-
superficial plexus, middle plexus, and deep plexus?
Yes, in all the cuts you can see, but the resolution is slightly lesser in the larger cuts.
Yeah, okay. And which do we think more important? Which do we take as more
word
important?
cut is a little misleading.
Cut is when you look at the various layers rather.
So,
Yeah.
Plexus, retinal capillary plexus, deep plexus,
size of
avascular
the
retina, RP, as well as chorea capillaris and the Raja choroidal vessels. So you have multiple layers which can be visualized. We have small areas which from the area which is scanned starts from 3 millimeter, and you have next 6, next you have 8, and then you have the maximum. Currently, most machines have 12, not beyond that. So depending upon what you want to see, you look at which cut, you choose which cut you want to take.
Yeah.
That's what I wanted to put across.
And one more question I see, sir. In an inflamed vitreous, can we inject like that? The question is there. Probably he's referring to that tuberculoma, Avastin. When there is vitritis, can we inject?
Yeah, because we had an inflammatory as well as vascular component. Apart from treating with ATT and steroids, to counter the vascular component, we had given anti-VEGF. And if you look at the PGA group, they had tried to avoid ATT and give only anti-VEGF in some of the cases of tuberculoma, where they showed nice resolution of tuberculoma without ATT, only with anti-VEGF. So that also series also is there. So we'll have to decide what, I mean, that probably we don't do in our practice. We try to address the primary infection also, but that's what we have been.
Yeah. And in a routine daily practice, how many autofluorescence will you do, sir, at Aravind? Like how many on a daily practice? 100
all uveitis patients, we do it as a routine, sir, autofluorescence. But some of the case of dry AMD, to see how far the geographic atrophy is there, whether they're extending into subfoveal zone. Even though OCT also will give you some idea. So it's much more spectacularly seen with the FAF. So main use is mainly all uveitis, posterior uveitis patients, and some of for dry AMD and such cases.
Will the panelists like to add, sir? How many autofluorescence in a day will you order? Like roughly?
We do more lot of. We also do it for CSR, because that gives us a very good idea.
Yeah.
And hereditary macular dystrophies. Many of these macular dystrophies, you tend to diagnose based on autofluorescence. Even Stargardt's, you have a typical pattern. Various types of you have those vitiliform lesions, which you can characterize these vitiliform lesions based on autofluorescence. So definitely for these, we get it done, besides what Dr. Saravanan rightly said.
This is one of the very classic examples, because best at the vitally eruptive stage, it can look like a subtle serous choroid.
Correct.
It can you can mistake it for something looks like a fluid, but you know that there is no leakage on fluorescence angiogram. So OCT, the autofluorescence is classic in BEST. So that's a very good example for that. And also prediction of vision in patients like Dr. Raju mentioned, RP atrophy, how much of geographic atrophy is there, which may not be clinically seen, is seen much better in an autofluorescence image.
Yeah.
Actually, it's nothing much like it, but doing a OCT, many of these machines will have an AF along with that. So you just click that image as well.
Yeah. Sriram, any questions from your end?
I have a question for Saravanan. Can I ask a question for Saravanan?
Yes, sir. Yamar, sir. Yes, sir.
Saravanan, you are showing that chronic CSR patient, and that you are talking about the enhanced imaging, which initially it was not there, but the enhanced imaging showed that little amount of subretinal fluid there. So
That was actually a physician who had undergone focal laser for suspected diagnosed as CSR, and two sittings of laser was done.
yeah,
And he came to us with persistent fluid in spite of 2 sittings of laser. And the fluorescein he showed was just a diffuse leakage, was not very clear cut. But when he did a OCTA, it proved to be a pachychoroid neovasculopathy rather than a CSR. So the whole diagnosis and treatments now changes. Now we have to do either injection anti-VEGF or do a PDT, and focal laser is not going to help. So this is one of the niche areas where OCT is really helpful. This pachychoroid neovasculopathy, it's very difficult to diagnose with routine imaging modalities, and OCT is very critical to. It gives you a very nice way of when looking at this actually.
you mean the swept source OCT will be better for this?
Yes, sir. Yes, sir. Routine OCT will just show a shallow PED, but OCT angiography will show that there is a network sitting underneath that.
Okay,
Yes, sir.
thank you. Sriram.
Just only I want to add a point to what Saravanan showed in his talk about superimposing what you see on OCT or OCTA with your fundus picture. Because a lot of times we get pictures of OCT sent to us on our phone or OCT and it's just one single line scan and we don't know what is happening there in the fundus. So it is very important to actually correlate it with the area in the fundus. You had one superimposition slide there. It was a very nice slide which really drove home the point that you have to see clinically. Either you see it clinically or you see it in the fundus picture to see what is actually happening in the fundus in the place where you find the pathology in the OCT. Because a lot of times you get just one single slice of OCT and I expect you to make a diagnosis and also advise treatment on it through WhatsApp.
It's not a magic wand.
Actually, truly the multimodal.
So that correlation is.
Yeah, actually, no. Truly, the multimodal imaging is that the same machine does all of that.
Yeah.
So that you can get these all what you are telling superimposition. Even
Automatic correlation.
Yeah, like we have one OCT machine which has a microperimetry built in it. So you know the retinal sensitivities at each point. So that is the ideal way of a multimodal. Though we talk multimodal having same patient on different machines, but ideal is to have multimodal on one.
Which OCT is that, Rajiv? Microperimeter with
it's Optos OCT.
Optos, the white field.
No, not the white field. Optos.
No,
OCT.
not the white field, sir.
No, I'm not.
OCT.
Guys, same guys. Same guys who have got
Same
the white
guys.
field. Yes,
Same guys. They have stopped the machine now, so don't get the spares.
Oh, really?
Used to
So
be.
microperimetry is now not working, so we are not able to repair. But that gives a functional thing. So you see a CNVM and you know what is the sensitivity above it, whether it's absolute scotoma, relative scotoma, after treatment, what is happening. I think so. That is the importance of multimodal. You have multiple things. The same thing like a spectralis, it gives the autofluorescence, and you have a angiogram and you get the OCT. You can correlate because you can do point-to-point correlations.
And the experience on intraoperative OCT.
Yes.
Any experience?
I also wanted to ask the same question.
Yeah.
Right now, I think not many centers are having it because of the cost involved, and the amount of application is very limited. So the cost does not explain the application. So if it's a little bit cheaper, everybody will have it. Because it's expensive, nobody's having it. But it has its niche role. So intraoperatively, suppose you're doing a ERM paying and you doubt whether it has ripped up caused a secondary macular hole, or whether you have peeled the ILM properly to identify various chytic layers during both DR as well as myopic macular schisis cases. It has got a very niche role. The only stopping point is the cost, and then application does not justify the cost, especially in a little bit smaller centers. Probably bigger centers can buy them, but it definitely has a role. There's just no doubt about that.
When the dyes were not available, it definitely had a role, but with dyes being available, its role is very, very limited. Another major drawback is the metal instruments interfere with the visualization. So when your instruments are inside, you don't get a good image. So in fact, they were trying to come up with a plastic instrument so that like you're able to go through them. So that's like adding to your cost. So I would think it's probably not a great the promise it didn't live up to. So it may not catch up so well actually.
And even I'm not sure about the resolution of that OCT.
That's not very So especially in a mobile eye, when the eye is moving a little bit, it is very difficult to get a proper image.
Even normal OCT, little movement, you need a very high acquisition speeds. And I doubt that that type of acquisition speed you will get with those cameras.
Don't you think it'll be a distraction while doing the surgery?
No, so it's not.
You can switch it on and switch it off.
It's not put on mode. Only during
Put it
critical
on and
areas
switch it
it's
off.
switched on.
Switched on.
You don't so switched on only during critical times. It's not like always on.
You can bring it on and off.
Probably like the C-arm for orthopedics.
Yeah.
Probably.
Something
It's
like
like
that.
this.
Well, but the Cyrus Shop's presentation I
It's
saw
like the
that day.
toric marking, sir.
Yeah.
Yeah.
It's like
Yeah,
toric
yeah.
marking. You can switch it on when you want. You can take it off also.
Callisto. Yeah. Similar to.
Yeah, like
Yeah.
Callisto. It's like Callisto. You can switch it on, switch it off.
Okay. I saw Cyrus Shop's presentation wherein he uses a video OCT and to intraoperatively and to find out the various layers of the vitreous cases, whether he's peeling it properly and all that.
It's like this: who has bought it, will present it. That's how it is.
No, it's not the IOCT. It's not IOCT.
Okay, sir.
It's not IOCT.
It's a 3D visualization, sir.
3D visualization.
3D
I don't know
visualization.
whether you've seen his presentation. He
Sir,
did-
the NQT, the 3D visualization has incorporated the IOCT into their system, sir. So it does not help you while doing the procedure. It will help you to identify pre and post peeling, whether you have completed your peeling and like that. You can, as sir said, all the instruments will obstruct the rays of light. So when you're doing the procedure, it's not going to offer you much because again, you said it will be distraction. Rather than looking at the retina, if you look at the OCT, is going to be distraction also. So this 3D visualization incorporate the IOCT into their system. That's what Cyrus sir was showing.
Yeah. Very nice.
Great, great, sir. One other question is being typed in. It's 9:30 and somebody's still typing in questions. They're asking, will OCTA kill ICG and FFA?
Not never. Both have their sort of a complementary role.
Everything
A
has
complementary role. Yeah.
Yeah,
It's
Yeah,
up to us to
surely,
decide
surely.
how to get the best out of the technologies.
surely. But at least when we started learning Retina, it was the pre-OCT days, and we understood the paradigm shift to OCT created to Retina. Now OCTA, I'm sure, will make a lot
yeah.
of impact into what we understand of the retinal vascular diseases.
No,
I
Frank.
think,
Yeah.
yes, sir. Yes, sir.
Rakshakar,
Yes,
I
sir.
don't, since you asked that question, frankly speaking, since all the top retina guys are here, don't you think we do less number of angiograms?
That is true, sir. That is true.
Yes.
That is true.
Very less.
When compared to about 10 years back.
Exactly.
It's
That
because
is
of
very
OCT,
true.
not because of OCTA. That's because of OCT.
OCT.
Because of the OCT.
Because
that's
whatever it
what-
is, the
OCT.
treatment is the same.
I'm talking about
So
OCT. Yes.
OCT, yes. OCTA, no. OCTA, yes, it has decreased the number of angiograms, but it's not the same. And there are certain situations where you still need an angiogram, but
Yeah.
particularly under the RP, ICG is required. If ICG is not there, you can do an OCTA and OCT and come to a reasonable diagnosis. So ICG, yes, a large number, it has come down because you can make a diagnosis of PCV with just the OCT characteristics or with a little addition of OCTA characteristics. But FFA, yes, you still do, but much lesser.
Much less.
Yes.
It's also got to do with our over-reliance on intravitreal agents rather than laser and PDT.
Yeah.
We've totally shifted away from that. Now you don't need to
Correct.
know what. All you need to know there is activity and you inject.
Whatever it
That's
is, you inject. That's how it is.
Inject.
Inject.
And the next casualty is grid. Nobody does grid anymore.
Even before, grid laser was not that very effective. Focal laser was okay, but grid laser, the efficacy was not that very great. So now the grid laser is almost dead, if you say.
Dead. Yes, sir. Almost dead. So probably
Actually, focal
we'll reinvent,
still
unlearn
has
and
a role.
reinvent us.
Focal still has a role, but unfortunately it is underutilized.
Yeah.
Because it's easy to inject.
Grossly
And-
underutilized.
Yeah.
And in fact, sir, Mohan Rajan, sir, if I have my fluorescent angiograms for diabetic retinopathy to pick up new vessels
Yes.
has drastically gone down after I got a wide field camera, even on OCT.
Yes.
Whitefield
Because it
camera.
gives you much more wide field fundus camera.
Opto, sir. Which
No,
one?
I have a Claris,
Okay.
but it gives you much more stable view. You can sit and pan the fundus slowly and look for new vessels rather than having an uncooperative patient and he trying to blink
Yeah.
and stuff like that. Sometimes you get frustrated. You think, okay, as well do an FFA to see whether there's PDR or not. But This is much easier to pick up the new vessels clinically on the fundus picture rather than doing a slit lamp biomicroscope.
Very nice.
Beautiful, beautiful, sir. I think 2.5 hours well spent. President, sir, closing remarks.
I think it's probably one of the best master classes. I was not there for a part of Manoj's talk because I had to go for the RT Center webinar. And I'm sure because I've listened to Manoj number of times and I'm
Manoj
sure.
had become a OCT salesman. He sold so many OCTs today.
Fantastic. And he's too good on this because a couple of weeks back, in fact, we had a class on the Rajan ophthalmic series, and that also we had a good presentation by Manoj and by the other retina specialists of Rajan as well. I'm sure it is very nice, and Saravanan was really outstanding and was there and is really fantastic. And of course, the panel is really a super panel. Yeah, I think they are all superstars of ophthalmology in our country. Rajiv Raman and Mahesh, we are very fortunate to have both of them here. And the Dr. Sriram Gopal, the what do you call it, the budding retina guy who's really making a big mark in southern Tamil Nadu, I would say in the central Tamil Nadu, and he's having a huge practice there, huge retinal practice. Very good name. I'm very proud of Sriram Gopal and is also very active in our TNOA and very happy for him. And of course, Dr. Rajshekar, the guy who is really leading from the front as far as the ARC TNOA is concerned. So many programs we have put in this already in 6 months. We have rolled out so many programs, and all of them are very, very really gems. Each one masterclass, if you see, the third masterclass was better than the second. The fourth one was better than the third. The fifth one was better than the fourth, and the sixth is better than the fifth. So it's like that. Every masterclass is bettering each other, and it's all because of the masters, the true masters here, Manoj Khatri and Saravanan and all other people. I'm very, very thankful to all of you for taking part in this. Despite being almost 10 o'clock, everybody is listening, everybody is watching. That shows that's a reflection of the high quality and high, clinical content, which is very, very necessary for all our postgraduates, residents, and even ophthalmologists for that matter. And I request Dr. Rajshekar to give the vote of thanks.
Yes, sir. Yes, sir. I wish we come back to the same panel and to the same masters with the topic on surgical retina. I think the honor should be Sriram for giving the vote of thanks. Sriram? Sriram?
Yeah, muted, not able to hear.
Sriram, you are muted.
Now?
Yeah.
Okay. Okay. Thank you, one and all.
Again, we can't hear you.
Thanks to
Yeah,
hear me
yeah,
now?
correct. Yes, carry on.
Thanks to both our speakers, Manoj Khatri and Saravanan, who kept us engrossed. We didn't even know that such a long time passed since we started the meeting. And expert comments from Dr. Mahesh Shanmugam and Rajiv Raman. And thanks, Dr. Rajshekar, for collating all the questions and bringing them out in a very eloquent way. And our dear president, the man who's leading from front, Dr. Mohan Rajan. Cheers to you, sir. And I'm sure this is just one of the multiple feathers you have having in your cap. I'm sure it's getting pretty heavy by now with all the webinars, and I'm sure this will keep carrying on for another few months. And thanks to our digital support team who've done a flawless job without any glitches and etc. And thank you, one and all. Thank you so much.
Big thanks to
Thanks a lot,
Milmet.
sir. Thanks a lot.
Milmet, and
Big thanks to Milmet. I forgot about them.
we'll be posting the YouTube recording of this particular webinar by tomorrow so that everybody can have a look at it.
Yeah. And it will
Sir,
be
can I have
perennially
a small
available.
suggestion here, sir, for TNOA?
Yes.
Sir, can I have a small suggestion here?
Yes.
All these webinars, which links you have on YouTube, why don't we have those links posted on a separate tab in the TNOA website?
Yes. We'll do that.
Sure. Very good idea.
Because now
Sure,
if somebody wants to go back and see a particular talk, they'll have to go and look at the old WhatsApp records and stuff. So TNOA, you can put this year, all these talks, YouTube links.
Absolutely.
So whoever goes and hits them, they can access that talk because
We'll
it's
do
going
that.
to stay there.
We'll do it right away. And
And
also
we'll get a lot of clicks.
another suggestion which I've been thinking was to get all the postgraduates into the Zoom instead of the YouTube or the Facebook, because we bring them into the Zoom so that some sort of interaction will be there.
Yeah.
Otherwise, it's more
That's
or
a
less
good
a one-way
idea.
talk, and they
Yeah,
ask
that's a
questions.
good idea.
In the world, they chat box.
We can get a minimum of about 300 to 500 people on the Zoom, and even we have a Zoom capacity going up to 1,000 people also.
Yeah.
So, even if we're able to get about 300 people on the Zoom postgraduates, it'll be very useful because interacting with them, it's like almost like a physical class.
Yes, sir. Yes. Yes. Thank you, sir. Thank you, one and all.
Thank you so much.
Thank you, everyone.
Thank you, Manoj.
Thank you, sir.
Thank you, Manoj.
Super ಆಯ್ತು ಸರ್ ರಾಜಶೇಖರ್ ಸರ್.
Fine. Wonderful. We Manoj இருந்தா அவ்வளவுதானே.
என்ன சாப்பிட்டீங்க இன்னைக்கு? என்ன சாப்பிட்டீங்க?
நீ 10 மணிக்கு தான் சாப்பிட விடுற. இது முடியவே இல்ல. Long class. We started at 7:30 and we have come almost to 9:50.
நம்ம மீட் பண்ணலாம் ஒரு நாளைக்கு.
கண்டிப்பா.
Sure sir. Bye. Good night.
Sure. Bye.
From here, I'm ending the meeting.